medicine have learned a lot from collecting data across multiple sites and multiple states. The challenges are there. The data I won't be sharing with you today, but it is being finalised, and hopefully we'll be able to share that in the future. So these are just some of the challenges that we've had with it. Sorry, I'll go back one. What the biggest challenge in this one was the comorbidity data being problematic. It was not aligning neatly with the patient list because of all the different multiple sites. But from the research team's perspective, the data custodians were extremely generous with providing that data, and we would often go back and ask for more clarity with the data, so we'd like to thank the data custodians for all their input as well across multiple sites. So implementing change is difficult. Themes to implementation team at Accelerate Plus and the implementation program are here. So at the top, you've got your individual clinicians and multidisciplinary teams, so different skill levels. Team members change, which often happens. We get new members into the team, particularly medical team changing. Disruption of habitual ways of delivering care. So where we're used to doing something one way, we don't really want to change. How are we going to work together? How are we going to do things differently? And then the complicated context of something which was very relevant to all the sites was COVID. So we had COVID in the same time we were implementing as well, so that was another challenge. And specific to probably the Prince of Wales Hospital was our move to the ASB. So in 2 of the first original units, our move to the ASB, changing roles in nurses and leadership at that time as well. So what I would like to share today, and so that we know why we're here and this assessment week, we're actually accomplish what we aimed out to do. So I just want to share a snapshot of the survey. So that's the surveys for the patients, nurses and doctors. Okay, so it's just a snapshot. So the safety for the nurses results, the safety attitude and climate amongst nurses significantly increased overall, and for the subscales of teamwork and safety climate. Barriers to nurses' use of physical assessment significantly decreased overall and across almost all subscales. Nurses' readiness to change significantly increased overall and for all subscales. Nurses gave their unit a higher overall rate of patient safety and Accelerate Plus intervention compared to pre-intervention data. And nurses' perception of collaboration with doctors significantly increased. So the doctors' survey results. Safety attitude climate amongst doctors did not change. Doctors' overall grade and patient safety did not change, however both pre and post results were very high. Doctors' perceptions of collaboration with nurses significantly increased overall in the subscales. So communication was one. So communication and important information from doctors is always passed on between nurses and doctors. Accommodation, nurses are usually willing to take into account the convenience of doctors when planning their work. So isolation, not working in isolation, but working as a team. So patient survey results. Oh, got over. I timed this to 12 minutes as well, and I thought extra time. Patients reported a significantly higher overall safety score. There were significantly higher scores post-intervention with subscales of resources, ward layout, time layout, staff roles and responsibilities. I better go quick now. So just a quote from a nurse from the process evaluation. I had another staff member saying I was just new to the ward and it was one of the reasons why I wanted to see working on the ward, because she was a casual pool and she found that she gave better care now. And just maybe one quote from a ward nurse. I think staff realised that we could make a change. And I'll have to stop now. Thank you. Conclusion. The project empowered nurses with knowledge and tools required to conduct thorough patient assessments and engage in effective handover practices. By focusing on nursing practice foundations and patient assessment and communication, Accelerate Plus has enhanced physical assessment, patient safety and interprofessional collaboration.
We'll hold over our questions until lunch break, and I invite everyone to collaborate and work at the bottom of the lunch break. Thank you. Thank you. It's now my pleasure to introduce our final speaker for the session, and that's to welcome Gemma McCurlane, who works at the Centre for Research for Nursing and Health at St George Hospital, and is also Associate Professor in Nursing at the School of Nursing, University of Wollongong. Gemma will be discussing nurse initiation of CPR in deceased patients without DNR orders. Her presentation will explore the ethical and practical considerations of this critical aspect of nursing practice. Please welcome Gemma. Sorry, just a slight technical issue. Thank you. I'm Gemma, and I'm going to present a large multi-site study that we did looking at nursing initiation of CPR in hospitalised patients without signs of life or a DNR order. Just to note that I know that it's variously called not for resuscitation, do not attempt resuscitation, and a few other terms, but I've called it DNR throughout this, so do not resuscitate. I'd also like to acknowledge the traditional custodians on the land on which I'm presenting from today, and that you're all on as well. And the alignment to the strategy is this study fits into the delivering high quality, safe, person-centred care. It's about creating conditions to utilise evidence to assist in developing and delivering person-centred, high quality and safe care, and the priority areas that it crosses, developing person-centred cultures, creating a supportive practice environment, and also building research capacity. Because we had lots of people involved in this team and quite a few people who've not done research before. So I'm going to start by introducing you to Mr. D. So Mr. D is a real person. Some of his details have been changed. Who is the reason that we did this study. So he was an 84-year-old man with metastatic lung cancer admitted to an oncology ward here in Sydney. He came in with widely disseminated prostate cancer, metastatic prostate cancer. He had a fracture of his left sacroiliac joint, increasing pain that wasn't amenable to radiotherapy. He ended up experiencing an agitated delirium and had worsening electrolyte imbalances. So after a period of time, a meeting was called with his family and the medical team, and a decision was made that he would be discharged home to receive end-of-life care there. However, on the 12th day, Mr. D's pulses cold, blue, stiff, but he didn't have a do not resuscitate order. So the nurses did what they thought they had to do, and they called a code blue, and CPR was commenced and continued for 20 minutes, which was futile, with the ICU nurse notes even noting that she could not get the oxygen probe due to rigor mortis. That was obviously incredibly distressing, and some senior nurses went to the institution's clinical ethicist to talk about the story. To talk about the case. So the clinical ethicist had a meeting with the senior nurses on that ward who were involved in that incident, and there was very clear agreement, acknowledgement that CPR in that situation was not going to be effective, was not in the best interests of the patient, and it was completely futile. But they also had very, very strong reasons for doing what they did and believing that they had to do that. And those reasons were around a legal obligation, so unless there was a written order, they have to do CPR. The CPR should be initiated without that DNR order. The nurses would face criticism or disciplinary action for failing to observe the patient prior to death or failure to initiate CPR, and that nurses cannot make a determination of death. And that once CPR has started, that only a doctor can authorise the discontinuation of CPR. So the clinical ethicist took that back to the district clinical ethics team, and with the ethicist and the lawyers involved, it was actually discovered that there is no policy or legal obligation to commence CPR in the absence of a DNR order. And this is just a selection of New South Wales, Queensland and Victoria policies which say that we don't need to do CPR if we can see that the person's been deceased for some time and the death is considered obvious and there's no clinical assessment required, that not having a resuscitation plan does not mean that resuscitation is a default action. That if the resuscitation management plan is incomplete or unclear at the time of acute deterioration, attending clinicians must exercise their clinical judgment and be prepared to stand by that judgment. That decision, that life-sustaining measures can be withheld, that it is appropriate to withhold CPR when the patient is exhibiting obvious signs of death, and that if there is no prospect of resuscitation, resuscitation should be withheld if the estimated downtime between collapse and arrival of the first responder exceeds 10 minutes. We ended up writing that up as a case study, and it was published in the Hastings Centre report called Raising the Dead Limits of CPR and Harms of Defensive Practice, so you're welcome to have a read of that if that is of interest. But in concurrently with writing this up, I ended up asking 10 of my nursing friends what they would do in that same situation with that same gentleman in that story. And 100% of them all said that they would do CPR. And when I asked them why, they said because they would not risk the registration, that their profession was too important to them to make a decision in any other way. So that made me think, are my friends misguided? And I thought, what better way to answer that question is to do a research study. So we ended up doing a cross-sectional survey looking at the views and experiences of nurses regarding initiation of CPR in hospitalised patients who are found without any signs of life in a do not resuscitate order. It was a 2-scenario survey. There were 21 questions and it took about 10 minutes to complete. This is the standard research slide that you see with the demographics and the 5 hospitals involved. So it was run across Wollongong, Blacktown, St George, Royal North Shore and Prince of Wales, and we had, after all of our data cleaning done, we had a response rate of 10.8%, or 530 nurses completed that, and if you were one of them, thank you very much. The majority were female, most were aged between 20 and 30 years, had between 6 and 10 years experience, were working at a registered nurse or registered midwifery level. Highest level of education was bachelor's degree. Highest level of CPR training was basic life support, or the alternate was advanced life support. Worked across all of the specialties within the hospital, and over almost 3/4 had initiated CPR before. Just to explain how the survey worked a little bit more, when we presented the scenarios, people could choose between, the question was, what would you do with regards to CPR or calling code blue? So they could either call a code blue and commence full CPR, they could do a limited form CPR, so that could be a slow code or a show code, that kind of, the sort of the more performative active doing CPR, it's more about the optics rather than they're actually intending to resuscitate someone, or would they confirm the patient had no signs of life and report the death. And with reasons, so we asked them, what would you do? And then we said, and why would you do that? And we had 18 reasons why, and they were broadly categorised into these 7 domains. So was it about managerialism, defensive practice, ethical or clinical judgment, harm to the patient, I'm running out of time, harm to nursing staff, or the nurse is not prepared. So you know Mr. D, he's the 84-year-old man, and the scenario ended with the nurse walking into his room on that 12th day, and he is found unresponsive, cold, cyanized, pulseless and stiff. What do you do? And then we also presented them with the second scenario, which was a younger man with a different clinical picture. So he comes in after a motorbike accident, he's got multiple rib fractures, a pelvic fracture and a femoral shaft fracture. He has some surgery, spends 4 days in ICU, and then he has just been, he's now under your care on the ward. Everything's going really well, appropriate pain relief, TED stockings, all that kind of thing, no major concerns, on 4-hour routine observations, and is expected to make a good recovery. But on the 14th day of admission, you enter and you find him also unresponsive, cold, cyanized, pulseless and stiff. What do you do? So if you were the older gentleman, if you were Mr. D, over 60% of nurses would perform full CPR, almost a quarter would perform limited CPR, and nearly 15% would confirm there were no signs of life. However, if you were Mr. G, if you were the younger gentleman, then over 90%, almost 94% would perform full CPR, only 23 people would perform limited CPR, and 9 people would confirm the death, confirm no signs of life and report the death. So the difference in that decision to do full CPR, there was a 32% increase, which is statistically significant. The top 5 reasons were that in the absence of a DNR order, there's no option but to begin CPR. I'm required by hospital policy to do so. I'm required by law to do so. It was what I was trained to do, and doing so enables me to fulfil my duty of care to the patient. The same for Mr. G, however, the duty of care reason moved up one, so people felt more of a duty of care to the younger person than to the older person. This is one of those slides we don't need to go through. You don't want to see as well in a presentation, but essentially it just shows that there are statistically significant reasons. People have different reasons for performing full CPR in both cases, with the exception of I'm not legally committed to certified death, I'm not confident I can determine if a patient is dead, and in the absence of a DNR order, there is no option but to begin CPR. People were able to write free text responses for their reasons, so these were some for the older gentlemen. So the only reason I would start slow CPR is that there is no paperwork or policies to support my decision not to. I will attend a full CPR as there's no legal grounds for a nurse to decide to do CPR even if the patient is dead. And since there is no formal documentation, we should perform CPR, however we will wait for the doctor to make a decision. And then for Mr. G, sorry, that should be the younger man, it says the person, they've chosen to do full CPR because the person doesn't have a life-limiting condition, the patient is young, expect to make a full recovery, this is an unexpected death and obviously a serious adverse event, and I would need to justify going against all policies as a nurse and to not initiate CPR. I'm sure there would also be an investigation. And this is an unexpected death, the patient was expected to make a full recovery. Although still futile, there is a good chance that he and his family will want an attempt at resuscitation. I'm just going to skip through the stats, but we looked at the associations with full CPR and also some predictors, and there are some predictors, but if we just turn back to the idea that over 90% of nurses said that they would do full CPR in that younger person, the association of predictors don't really matter so much. It's something that clearly a lot of us think we have to do. This survey, this slide was where we asked we asked them a knowledge-based question. So what percentage of CPR attempts achieve return of spontaneous circulation, and also what percentage of CPR attempts result in the patient being discharged from hospital? This graph is from the first question about the CPR attempts achieving return of spontaneous circulation. The answer to that, it is quite complex. It's dependent on a lot of things, but reviews say that the answer is between 3 and 18%. So it's not overly successful. But this just shows that our population, our respondents, didn't really know the answer. And then we asked who should make decisions about not commencing CPR. Over 90% said it should be a doctor, a quarter said it should be a nurse, and almost 8% said it should be the next of kin. And this is just one of the free text responses from someone where we asked if you've ever made a decision not to commence CPR. We asked if they received a positive or negative experience from that or outcome from that, and this comment was quite telling. So it's negatively impacted my practice and mental health severely. Even after escalating to my team leader, I felt solely responsible for the situation as the patient was under my care. Although some staff were understanding of the situation, I felt greatly criticised by colleagues. So in summary, my friends are misguided, but so are most of us, so I think that's all okay. The vast majority of nurses will perform CPR on patients with no signs of life in the absence of a DNR order. The reasons seem to be related to misperceptions of law, policy and duty of care. There are associations and predictors, but actually they don't mean a lot. We need to do something sort of broadly, not just targeting specific groups. Possible meanings are, let's assume that all nurses make well-intentioned decisions, and this presentation is certainly not a criticism of nurses. This data suggests that many factors influence nurse decision making around CPR beyond the direct clinical needs of the patient. So that could be related to the overestimation of the benefits of medical interventions, the imperatives of institutional bureaucracy and managerialism, is about a clarity of law or ageism or other. And then where we're saying go next is that we need further education for clinicians and policymakers on laws and policies surrounding the determination of death and CPR, appropriateness and success rates of CPR, the ethical and legal concepts including duty and care? Should we expand basic and advanced life support training to include education about when CPR is not required? And can we empower and support nurses to initiate and not initiate CPR? Future research could look at organisational research around policy updates and things like that, or looking at how pervasive this fear of law and policy is, or do I just need to get some new friends? So thank you. That is, we were a very large investigator team, and I also have to thank all of the sites who allowed us to do the study, and or to all the nurses who took time to do the survey. So thank you.
Great, and please stay, you'll be around in the lunch break, we'll be able to ask our questions. Thank you so much, it was a fantastic presentation. So with great pleasure, I draw to a conclusion or wrap up of session 2. I'll use the abridged version, thanks Dan, and thank Glenn for his data-driven insights surrounding patient journey. I'd love to thank Jude for the lessons learned through the COVID-19 pandemic and how we can practically make changes for infection prevention and control. Thank you to Yvonne, who has shared with us her research on accelerated plus and how that impacts the profession of nursing and midwifery and the great roles that we play. And lastly, thank you to Gemma, who has shared with us both the ethical and practical challenges surrounding caring for the deceased patient. With sincere gratitude, I'll invite Dan to wrap us up for next session or lunch break.
Thanks so much, Robert. Please join me in congratulating Robin and thanking her. What a great session, a great variety of presentations and lots of thought-provoking questions and where to next. So thank you to our presenters. We did have a 10-minute stand and stretch. I'm going to offer you 2 minutes to stand and stretch so we can get you to lunch on time. So if we just take 2 minutes just to move around. Shuki, you'd be happy to hear we're all doing a bit of pressure injury avoidance. So we'll take 2 minutes and then we'll kick off. Lots of standing, lots of stretching, vocal cords. Invite everyone to make their way back here and take their seats.
Both of you on brand.
All right, welcome back into the space. We're about to get started. Welcome back, and welcome back to those online. Thank you for joining us. As we move into session 3 and before lunch, I would like to welcome our chair for session 3, which is Lauren Sturgis, our Director of Nursing and Midwifery at St George Hospital. If you could meet Lauren and feel welcome as our chair for this session.
Thank you. Apologies about those of you that thought you might be heading to lunch. We've got another 4 presentations and we will make sure we stick to time so that you can get to lunch. But certainly the 4 presentations we've got ahead I think will sustain your interest and hopefully your hunger. As Dan mentioned, I'm the Director of Nursing at St George Hospital, Director of Nursing and Midwifery at St George Hospital. Which is an absolute privilege, and thank you all for coming today. We are very happy to host this wonderful event. Now, very fortunately and very kindly, Glenn has decided to do an encore appearance and he's coming back for another presentation. So I'd like to welcome back Glenn Paul, our Cardiology CNC at St George, for his presentation on chronic disease management and complexity science.
Thanks very much, Lauren, and I'll try and keep the microphone up to mount this time. So thanks again. This is sort of big picture stuff, I guess, and it certainly has applicability across chronic disease management, but I suppose a lot of the examples will be in my field, which is in cardiology and heart failure. I'd like to acknowledge country and alignment to strategy, developing person-centred cultures, creating a supportive clinical practice environment for our staff, building a dynamic workforce and delivering high quality, safe patient care. Chronic disease is complex. So similar to Brendan, I started nursing about the same time as he might have been a year ahead. He looks a lot younger. Didn't make me feel good. Chronic disease management is complex, and the take-home message today, we need to really understand that. We really need to understand and embrace the complexity of chronic disease and what's required. This is a typical chronic disease management network. This is realigning to chronic heart failure. You can see that there's a wide variety of settings. There's inpatient, outpatient, and home-based settings. And there's also multiple providers and services. On top of that complexity, we know that chronic disease is characterised by changes over time, and that they're more the temporal dimensions of chronic disease. And it's important that we recognise that chronic disease isn't just a spatial entity, it's also a temporal one. So it changes over time, that's very predictable. And they require healthcare models that are responsive, agile and adaptable in order to meet the needs of people with chronic disease. This is a typical trajectory. So people get diagnosed, they have a few acute episodic illnesses. A lot of chronic disease is characterised by episodic decompensation, but the gradual trajectory is normally down, and so we go through for a diagnosis phase and a dying phase. So it's extra complex. We've got multiple providers, we've got multiple healthcare environments, and we've got a disease trajectory where patients have changing needs over time. Simple systems do not adapt or change. So we need to recognise this complexity, and we need adaptable models that respond to changing needs of patients and their care partners over time. So what happens when we don't have in this trajectory appropriate model of care? Well, we already know. We have poor communication, inefficiency, poor planning and poor patient outcomes. Which brings me to the concept of what's changing over that chronic disease trajectory. And it's really a series of transitions. People are transitioning to a diagnosis of an illness and then transitioning through that illness, through those decompensations, those decreasing abilities to self-care, those admissions to hospital, discharges, multiple healthcare settings. And in order to target or in order to support the patients across that journey, we need to do the right things at the right time. Sort of a good sort of word for that is kairos, which is Greek for the right or the critical moment. So how does a healthcare service respond at the right or critical moment? And you can go back to Gemma's presentation where that person needed end-of-life care, that person needed an NFR order. So that's like trajectory appropriate care. When we don't have a trajectory appropriate care, patient outcomes are the worst for it. So it's timing of those transitions. So how do we support this, this timing? And this is where complex adaptive systems from complexity science comes into it. So complexity science is the study of complex systems, and we've ascertained chronic disease management in healthcare settings is a chronic adaptive system. And it's characterised by those dynamic relationships among multiple participants. The system is more complex than its individual parts. Multiple agents in dynamic relationships, and provides a framework for understanding the interactions which are required for chronic illness management. So the key concepts of complexity theory is, I'm just going to say non-linear, because I practice saying non-linearity lots of times, and I've nailed it then, but outcomes are not proportional. These are key concepts. Outcomes are not proportional to intervention, so care strategies must be responsive and flexible rather than fixed. Another important concept, emergence. Health outcomes emerge from interactions within the system, not just individual components. So improved outcomes may arise from better communication and relationships rather than just increasing the treatment intensity. Adaptation and feedback. Teams continuously adapt to changing conditions and demands, and that's through continuous feedback loops, like telemonitoring, PROMs, regular review, and they allow dynamic care adjustments within that team. This is the most important thing, I think, is self-organisation. If you've got the correct care networks with the correct approach, care networks self-organise around the patient needs and gaps in care. So care networks self-organise around patient needs and gaps in care, and this is through flexibility, allowing innovation and customisation of the patient-centred models which we're pursuing. So they're the key concepts of complexity theory. This is an example of a closed system. This is a complex adaptive system with closed borders. It's very limited flow of information, very little efficiency, very little interrelationship, as opposed to an adaptive system with open borders where you get this changing pattern and structure of interactions, but clear communication, it's able to accommodate change and plan of care treatment approach, and you have improved system and caregiver outcomes. So this is really just a representation of a service within a hospital. So this is our heart service. We've got the nursing roles in the middle in the yellow, which is we've got multiple clinicians involved with the patient and the care partner. We've got the other sort of outpatient home-based sort of services, your cardiologist, endocrinologist, respiratory physician, primary care physician responsible for chronic disease management in the Australian healthcare system. I'll repeat. Primary care is just responsible for chronic disease management in the Australian healthcare system. hospitals aren't. We have the acute episodic care, but our partnership with our primary care is important. So closed boundaries results in reduced information, reflects fragmented healthcare, and it's associated with high costs, poor outcomes, and low patient and carer satisfaction, whereas open borders and open communication reflect strong relationships, flexible roles, and reciprocal interactions. And this supports self-organisation, and that self-organisation is critical in being able to support the transitions of patients and carers through their chronic disease. Information moves along open borders, and there's reduced fragmentation. So, in conclusion, complexity theory has clear relevance to chronic disease management. Open borders and strong relationships allow care networks to self-organise around patient needs. Role flexibility allows for innovation and customisation of our care models. Embracing complexity requires change. It requires training and it requires systems thinking. But embracing complexity enables healthcare systems to deliver more adaptive, personalised and effective care. Thank you.
Thank you, Glenn. What was that word again?
Oh, yeah.
Yeah, that's impressive in itself. No, I'm not saying it. You'll show me else. Any questions for Glenn? I mean, I found that really, really interesting and very thought-provoking, Glenn. Particularly the role that the nurse plays in connecting all of those key individuals, which, you know, we never want to lose sight of because we are the best ones we're in the best position to advocate for patients and their outcomes. But the challenge around trying to create flexibility when we often also create standardised workflows and standardised processes is really challenging. But I found that very interesting. Thank you, Glenn. Does anybody have any questions or comments for Glenn? No? All right, you're off the hook. Thank you, Glenn. All right, terrific. So we're doing well for time. I think we are on track. So no pressure, Liz, as it's up to the group. So I would like to welcome to the, I was going to say the stage, we're going with stage, Elizabeth Schlossberger, Nurse Manager of Nursing Education, Workforce and Research at Prince of Wales Hospital. And today Liz is going to present to us building collaborative competence and enhancing and expanding leadership skills. Thanks, Liz.
Mic, can everyone hear me? Because the older I get, the less I can multitask by pressing buttons and clicking my notes. So, thank you everyone for this opportunity to present our presentation, which is building collaborative competence, enhancing and expanding leadership skills. The focus of the presentation is a model of leadership development we utilise for two of our leadership programs, the Emerging NUM program and our Aspiring Senior program. Firstly, I'd like to do my acknowledgements now and acknowledge that these programs have been developed and are delivered in collaboration with Sydney Eye Hospital. And also I'd like to acknowledge our Prince of Wales Foundation for their sponsorship, which allows us to deliver these programs in the format that they are. Most importantly, alignment to the strategy. So these programs actually, when we look at the strategy, align to multiple priority areas, developing person-centred cultures, building dynamic workforce, developing high-quality, safe, person-centred care. However, the key focus obviously is fostering leadership at all levels. And if we look at the strategic actions, we can align these programs and our leadership model that aligns with all of these strategic actions. So the person-centred framework, the person-centred practice framework provides us with a benchmark for measuring person-centred care and processes. It's a framework that underpins our approach to person-centred leadership development and provides us with guidance to ensure that we incorporate the different domains within the program. For example, this program sits within the macro context, which is the outer grey area. And I don't want to mark anything up, but you can see the outer grey area there, and also aligns to the strategic leadership and workforce development. So our important first activity that a new cohort of participants completes is values clarification as a leader, as working with values and beliefs is a pivotal person-centred process that we believe centres individual development. So these are the shared values statements created by our last two ENUM programs and our first Aspiring CNE program. In both programs, during their first workshop day, the participants co-create their value statement, which they now incorporate into their own personal leadership and ways of being. And this is just the three value statements from these last three cohorts. So our aims of the program is the aim of our program is development of a comprehensive skilled cohort of leaders using person-centred, multifaceted approach intended to support the development of nurses in their leadership journey. So both programs, as I said before, are run in collaboration with Sydney Eye Hospital. Our emerging program is now in its 6th year. It's a 9-year program, it's a 9-month program in duration. Each program will send out an expression of interest, and often we have over 50 EOIs for just 10 positions at Prince of Wales that we have on the program. Just last year, we conducted our first Aspiring CNE program. It is a 6-month, not year, program in duration. And again, applications via EOI, and we received up to 30 expressions of interest for just 7 positions that we have at Prince of Wales Hospital. So looking at a model of leadership development, that we have identified 6 elements to the model that we utilise. And they're just on screen now, and I'll just go through those now, each one. Firstly, we've got our preparation. So as well as the application process, which is the EOI as well, and also an interview, the successful participants are required to complete a wide range of online assessments and learning modules that underpin the knowledge for performing in their leadership role prior to actually starting the program. Secondly is our knowledge acquisition, and this is through workshops. These are our 4 full-day workshops, plus there's other further online modules that the participants do complete. Thirdly is our observational learning. This pretty much more so for our ENUM program, where the participants have the opportunity to spend 5 days with key healthcare leaders across the executive, workforce, patient safety, patient flow, our Director of Nursing, Finance, Human Resources and Education. And this provides an opportunity to widen their exposure to key management and leadership roles within the healthcare context, and also broaden their understanding of the role they play in delivering healthcare services to our community. The Aspiring CNE program, they have the opportunity to shadow our after-hours CNE. Sorry, going just back. Our 4th element is experiential learning, which is working alongside the NUM or CNE mentor. Mentorship is a critical component of the program and one that is highly valued by all participants. As well as the scheduled work alongside period, the participants also meet regularly with their mentor for the duration of the whole program, and they're encouraged to use reflective framework for ongoing discussions about their development and observations. The 5th element is workplace learning, and this throughout the program, all ENUMs and aspiring CNEs are encouraged to apply for acting NUM or CNE positions as they become available. So a key indicator of the success of the programs is the number of participants who successfully undertake these acting roles and go on to attain permanent leadership positions. And then the 6th element is our transfer of learning. Our ENUMs are required to undertake a quality improvement project and present this at their end-of-year program. Our aspiring CNEs have multiple workplace learning assessments, which include performing an assessment of practice, developing learning and development plans, delivery of in-service and co-facilitation of simulation-based learning. just highlighting particularly our fourth element, which is special learning, particularly around mentorship. As I said before, the mentorship is a crucial component of the program and one that is highly valued by the participants. The first activity they participate is in shadowing their mentor for a specific number of shifts, and then they actually take on the role with their mentor close by for support. This enables actually that first-hand experiential learning. As I said before, the duration of the program, participants meet regularly with their mentor and encouraged to use reflective framework. We also know, though, that equally for our mentors, this opportunity to work with a program participant provides for their own development, and many mentors stating their mentorship strengthens their own leadership development. So just a little bit around our evaluation, we do take a multifaceted, contemporaneous, that's my word that I always get caught on, contemporaneous approach, and use multi-methods to evaluate our programs each year, integrating evidence from all aspects of the program. The evaluation data is highly valued for contributing to the changes that ensure the program evolves, remaining contemporary and future fit. So we do have a future plan, longitudinal evaluation of the impact on workplace culture that these programs have. Evaluating some outcomes, starting with some workforce metrics. So of the 53 ENUMs, 90% have had the opportunity to act in NUM roles, and 35% that we know of, because we have had some people that have left, and hopefully into NUM roles, permanent NUM roles, but 35% that we know of are now in permanent NUM positions. So of the 53 ENUMs, 83% remain permanently still employed in Prince of Wales Hospital, so it's a good retention. We've only had one cohort of our aspiring CNE program. However, 75%, which is 5 out of the 7, and this is for Prince of Wales participants, have had the opportunity to transition into acting CNE roles. Which is pretty good since the program only just was completed in February. So, however, we feel the greatest success is visible in succession planning, capability and capacity of staff skilled to undertake the role of the NUM CNE. Developing a workforce of dedicated and committed leaders who contribute significantly to shaping the future of our healthcare. I'll go quickly because I think I'm running out of time here. No, am I right? So each year there is an annual report that's generated for both programs, and this is some general highlights from the evaluations. So that all our ENUMs stated that prior to the program they had little understanding or confidence in terms of undertaking the role of the NUM, and then on completion 100% of them have dramatically shifted to moderate or complete understanding of the role. You can also see very much so that 100% recommend the program to others. And just from our one aspiring CNE program, which the report's just been finalised, we're very happy to preliminary evaluation analysis shows on a pre and post program survey responses, there's a 330% increase in an excellent understanding of the role of the CNE. So, as I said before, our ENUMs support application of learning and practice. Each participant is required to undertake a QI project. This component of the program was only introduced in 2022, so we've only had 3 years. And you're not expected to read this slide, it is very busy, but I think we just wanted to make an impression over what the last 3 years have achieved. And these, to make it a little bit easier, are the themes from the last 3 years of QI projects. And with our aspiring CNE program, as I said, that they get to celebrate at the end of the program by presenting their key learnings. And these are the key things from the key learnings from our aspiring CNE program from last year. So we believe that we have a model of leadership development that enables the development of leaders who are safe, confident and person-centred, We also believe that the multi-methods of learning included in the program are relevant for all health disciplines and their leadership development. Just want to acknowledge that our program most of our program leads are in the room, and I have their names up there on the board. If you've got any further questions, please don't hesitate to contact them. Do visit the site hopefully.
Excellent presentation and a really positive reflection on the leadership program at Prince of Wales. You'll enjoy me doing a very similar presentation this afternoon about our program at St George. So sit tight for more of that. Well done, Liz. Thank you very much. Congratulations, Prince of Wales. I would now like to introduce Dr. Scott Brunero, hopefully I got that correct, who is an adjunct associate professor at UTS, Sydney and clinical nurse consultant at Prince of Wales Hospital. And Dr. Scott Brunero is going to take us through understanding the experience of workplace violence, developing a de-escalation model. Am I in your way? I'll move out of the way so you can get the slides ready. And while Katrina's getting the slides ready, as I mentioned, Scott's presentation is around understanding the experience of workplace violence and developing a de-escalation model. His research and expertise in this area will provide us with valuable insights into managing and mitigating workplace violence in healthcare settings, which unfortunately has become a real challenge for most clinical areas and certainly not a unique problem to Prince of Wales. So please assist me in welcoming Scott for his presentation. So flexible. Thank you. Thank you, ladies. Sit tight for Mary and Linda. They're next.
Okay, so this is aligned to the strategy. So my role at the hospital at Prince of Wales is I do some violence prevention. So I go to the Code Blacks during the day when I'm there, and I do a lot of violence prevention education as well. So I have a really hands-on exposure to violence at the hospital. So it's not going down, unfortunately. We didn't sign up for nursing. When we went and decided to do nursing, we wanted to care for people and look after them and all that. Unfortunately, there's a lot of violence in nursing. It's a very violent job. So about 25% of nurses report physical violence in the previous 12 months. And that's really across the world. If you survey nurses, they'll all say about 25% got actually physically hit. So it's an unfortunate part of our work, but we need to be tackling it. We can't just sort of ignore it. So it's part of our work. So there's lots of studies on violence. So what, with some colleagues, we wanted to do was look at really trying to understand a bit more the experience of how people escalate. How do these violent episodes escalate? And there's quite a bit of research on it. So it was originally a group wanted to go and interview our patients who become violent, but then they thought, okay, that's really, really difficult. We can't just go and interview people who are violent. There's a whole lot of ethical issues with that. So what we decided to do was have a look at all those IMS reports that people write. You've probably written some here yourselves. So they're analysed individually, but we wanted to have a global look at all the IMS reports that are written about violence. So I read them as part of my role every day or every few days. So we've done it Prince of Wales. So we've got all the IMS reports, we've got ethics approval, and so we did a thematic analysis of what all the nurses have been writing in those little text sections when you fill out an IMS report, to try and sort of gain an understanding of can we learn anything collectively from all that reflective writing. So most people do IMS like at the end of the shift or so. So they've had a bit of time to think about the incident and write down their experience of it. So we thought that was a really useful source of data, not just as one episode, but collectively look at a whole bunch of them. I think we had about 775 incidents we analysed, but they're only short, a few sentences each. So that's what we did as like thematic analysis of it. So these are just some of the demographics, getting a lot with incidents, but most violence in healthcare occurs in emergency departments, then aged care and neurology departments. So it's, and that's pretty international. And in this group, there's really a lot of young people, and that's probably reflected in the emergency data. And some of the diagnostic groups we know about already from other research, like dementia, delirium, acute psychosis, and a few of those. So that's sort of well known. So we sat down and we went through all these 775 incidents, which took a little while, but so we tried to theme them. We come up with some themes or categories of what was going on in the data. I'll go through just some of them. And then we tried to think, well, after theming, we thought, well, what can we do with this? We tried to come up with a bit of a model, another model of how people escalate. So the first sort of thing that nurses were talking about in these incidents, we thought was, we call it escalation dynamics. So how incidents escalated from verbal altercations to physical violence. So scenarios often started with some sort of verbal disagreement with patient and staff, generally related to some sort of treatment or care or that the nurse was trying to do with somebody. So we thought there was some sort of thing going on there. The next, we thought that nurses talked about identifying in the IMS warning behaviours. So they just started to describe situations where consumers verbally threatened or insulted healthcare staff, and really talking about how verbal threats or distinct non-verbal cues were predictors of physical violence. So there was a lot of writing about that by nursing staff. So the nurses also, this was very common, that authoritative interventions, we call it. Nurses describe how our sort of hospitals are very rigid. We have a lot of rigid policies and rules to follow. And when people are becoming aggressive, they don't like rules. So rules and aggression, they're not a good mix. So, and also using, security guards, those sort of really authoritative models were thought to escalate some violence in some situations. So that was something that nurses talked about a lot in the incident reports, relating the progression of violence to these sort of authoritative models and restrictive policies and security guard sort of approaches. So this is the other one that nurses talked about a bit. We thought was care delivery methods, how certain treatment procedures and approaches might inadvertently elicit violence in people, in our patients. So the method of care delivery, including specific treatment procedures, how that can sometimes provoke violent episodes. And these episodes occur during regular care procedures. So normal sort of everyday practices that some people just didn't like, and nurses thought that some of these things, this way we do things are catalysts for violence. And this example here, during a routine dressing change in the program, the patient grew increasingly agitated and began to hit the nurse. So some of the procedures we engage in are illicit violence, but unfortunately we have to do these things, procedures and dressings. So the other one was situational stresses, where we thought patients were in external circumstances or changes that acted as triggers. So there was a bunch of, environmental or situational changes that we thought were attributed to predicting sort of more physical violence episodes. And some of these, you'd be familiar with transfers and moving items in beds. So all those little small things like that could can predict violence as well. So situational stresses. And then there was a lot of incidents that nurses wrote about. There didn't seem to be any triggers. They're really unprovoked episodes of physical violence. The nurses couldn't, figure out what really caused that episode. So we think that's worthy of a category of unprovoked triggers. So we sort of sat down and said, well, what can we come up with some sort of model that maybe we can use in our education or in policy. So we're trying to develop a model of how people escalate. So if we have a model of how people escalate, we can then think about how to try and de-escalate situations. So what we've sort of so far called it is that we think that patients interact with an object or people. The patient then has to the next sort of step is where the patient attempts to self-resolve that conflict and generally resulting in an unmet patient need. So the patient's interacting with somebody or an object, they're attempting to resolve it themselves. The nurse then is enforced to go and interact with the patient. There's some sort of verbal interaction from the nurse. And generally, this is where we're sort of de-escalating. But often de-escalation doesn't work. If it is unpredictable de-escalation, and you end up in sort of a physical violent behaviour situation. So that's just another way. There's various models of escalation of violence, so we're just trying to think of another way to think about it. So our recommendations for this sort of study, violence has to be a whole of healthcare, whole of approach to whole hospital sort of approach. It just doesn't receive the attention that, say, cancer treatments do, or intensive care unit treatments do, or disease state treatments. It's not really seen as a disease state, so it doesn't attract that sort of attention, that research attention or clinical practice attention. But it seems to be endemic and involved in all of our patient areas. So violence is a funny thing. It's not really seen as being a clinical thing. It's like it's something we don't want to happen. But it is really a clinical manifestation of not only the disease states we have, but a lot of the processes in hospitals that we have to do to people. So we come up with some other ideas about having more focused on, rather than security guards, a lot of hospitals are moving toward the HASA model, the healthcare assisted model, so combining the wards and the security role. That's talked about a lot more. Person-centered care, really key component of that is being empathic, and empathy is a real key component in de-escalating people. So all that person-centered models we talk about, we've got to be talking about though empathy and empathy-centered care. So being empathic is the key way to de-escalate people. So training that we all have across the district, we have all those sorts of training models. And one of the things we thought about for our IMS reports is restructuring how we document violent incidents. So we've come up with a model from behaviour analysis really, but we need to change the forms a bit. They're quite hard to interpret. So we've come up with some questions that we could use in an IMS report to help us enable sort of analysing the reports a bit better. So based on behavioural analysis triggers and so that. So that's our little study on IMS.
Thank you, Scott. Very interesting and certainly a very, very worthy topic that has probably impacted many people in this room and certainly the clinicians that we work with. Does anybody have any comments or questions? Dr. Teresa Riley, up the back.
Scott, great presentation.
Thank you.
My question is just related to the last comment you related about the changes to IMS and about behavioural changes, and so is that indicators that would assist in identification or tracking, or what did you really mean?
What was I talking about? I think, in IMS, just the headings are a bit abstract. So there's a good basic sort of behavioural analysis model. So we come up with some questions that you could put in IMS instead of what's there already, which are very generic. So it's called a functional analysis framework, very well known, but some questions like please describe the triggers observed and unobserved prior to the incident. Get nurses to write that. Please describe the violent behaviour, give examples. And the last one is what was the consequence of the violence to the patient. So it's sort of consequences. So just restructuring how we're using them. So perhaps actually someone brought up the other day how we write about it in EMR as well. A similar sort of part of I think we might include this as part of our violence training, just how to document those reports a bit better. Yeah, that's all.
Is that with the intention of trying to elicit more meaningful information?
Yeah, sure. You're trying to understand more about triggers. So we do a lot for violence. We do a lot of, we all have code blacks, and we sort of wait till it happens, till it becomes violent. I mean, we have code black models and security guards and all that. So it's really trying to get us to think a bit more about those triggers that earlier sort of, so we can prevent violence, earlier intervention. So just trying to get nurses to document about triggers a bit more, I think. Antecedents is the word. So.
Sorry, Scott, just to follow on from what you've just said there. So then would that mean, or would we then change the way or reframe education to include more about triggers so that we're thinking about at the beginning and instead of when we've captured that there's been an event and we're looking at those, could we possibly do that? I know that you do a lot of training.
Yeah, we do a lot of training, but yeah, it's not enough on the triggers and then the de-escalation component. And Hetty is sort of reviewing at the moment. They're sort of a bit focused on the hands-on restraint type stuff, which we all like. It's fun to do. I like doing it. But you've got to, it's more important, the triggers, the risk assessment, the assessment of triggers, and how to then de-escalate. It's really got to be the focus of training. If you're having to go hands-on, it's all a bit too late. You've missed it. We've missed it. And sometimes we do. You can't predict it. It's very unpredictable, but it's about sort of getting that attention back to those, understanding the risks and the triggers, and then early de-escalation is the really key to violence prevention.
Terrific. Any other comments or questions? All right. Thank you, Scott. Okay, we have a much awaited third presentation that is now fourth. I would very much like to introduce two of our very, very well-regarded CNCs at St George. Mary Dunford is our CNC of Respiratory and Linda McGann is our CNC of Palliative Care. And they are here presenting on behalf of Mary Lafferty, another of our wonderful CNCs in palliative care. And they are presenting on the level of dependency, withdrawal of non-invasive ventilation framework for NIV, high-flow nasal oxygen in end-of-life care. So I've got all those acronyms out there for you, just in case you weren't sure. And I will hand over to the both of you. Timekeepers there. No pressure.
We'd also like to acknowledge country. Okay, delivery of high quality, safe, person-centred care. So we measured on a couple of criteria. We ensured that the person is centre of what we are providing to access holistic care that is flexible, coordinated and collaborative. NIV and high flow is used by the respiratory and palliative care services in end-of-life settings to relieve dyspnea and a sequel to nocturnal hypoventilation to allow patients alertness and communication and buy time. There is no ethical reason why ventilation should not be discontinued at a time decided by the patient who has decision-making capacity. Staff carers who are skilled in non-invasive ventilation and high flow should be available during the end-of-life care to ensure that it is used appropriately and that it does not cause increased symptoms to the patient. We also looked at solutions to utilise the evidence to assist in developing the delivery of a person-centred, high-quality care, safe care. We identified a trend in the dependency. So basically we were seeing that we were having terrible deaths of patients who were on non-invasive ventilation, who've been dependent on that machine and now wanted relieved. We have more deaths on the respiratory ward, only second to ICU and the emergency department. So we needed to make sure that when we were withdrawing non-invasive ventilation, we were doing it well, so that we could support patient on their end-of-life journey. So just for the audience, we're talking about hypoxic failure being respiratory failure or type 1 failure, defined as a PaO2 of less than 60. On room air, that would be your pneumonia patients, your heart failure patients and your pulmonary fibrosis patients. And those that are in hypercapnic respiratory failure would be type 2, would need non-invasive ventilation. That would be patient with PaCO2 of greater than 50 on room air, with the mechanism being respiratory failure or neuromuscular weakness or stroke or other respiratory conditions, COPD, etc. So when to consider palliative care? In respiratory failure. find there is no relief from breathlessness despite optimising the medical treatments, have increased and more frequent admissions to hospital, have limited improvement following the last exacerbation, start to voice, am I going to die this time? Sometimes patients have 20 admissions, they've been on ventilation for 5 years. Every time they come to hospital, they think they're going to die. Express fear and anxiety with the development of panic attacks. Ethically, there is no reason to continue the NIV when this is futile. So what did we do? We witnessed inconsistent symptoms management of end-of-life care in patients with end-stage respiratory failure. Sometimes we got it right, sometimes we didn't get it right. We wanted to get it right for every patient, so we needed to look at what we were doing more closely. We looked at the literature, and there was very limited literature available with withdrawal of non-invasive ventilation at all. There was a bit in ICU, but nothing else, and there was very little in respiratory failure and end-of-life care. There was a little bit of literature in motor neuron disease, nothing else. And there was also a lack of specific medication doses to assist on the withdrawal of NIV. So our study looked at 81 patients over a 6-year period. Outcomes assessed were respiratory symptoms of dyspnea, anxiety and agitation. We looked at the type of oxygen support at time of death between 2015 to 2018, and after 2018 to 2020, post the implementation of the level of dependency withdrawal of non-invasive framework. All of the above data correlated led to the development of the enclosed level of dependency withdrawal of non-invasive ventilation support framework. Okay, so just so you understand the framework we developed, level 1, if you look at the green, we use the traffic light, is periodic use. The patient uses it at night, not every night, but it helps with their breathlessness. Level 2, they're using it every night, and they're at like 4 hours on, 4 hours off during the day. And level 3, the patient is on it continually, cannot take it off even for a sip of water, very dependent on their mask. Their mask is like the mask is treating their dyspnea. So what we did, we did an analysis of the prescribed and administered medications was conducted to identify an optimal medication regime for the withdrawal of non-invasive ventilatory support. In addition, we looked at conscious and unconscious states of the patients were recorded, and that helped us to recognise the implication for specific doses and the level of non-invasive respiratory support of non-invasive ventilation and high-flow oxygen patients was received upon referral to the palliative care team, was integrated into the framework.
So for anybody who's looked after a dyspneic patient at the end of their life, they will know just how complicated it is. Those of us that work in palliative care will tell you that breathlessness is a much more difficult symptom to manage than even pain, because remember, the more breathless you are, the more frightened you feel, which makes you more breathless, which makes you more frightened. So being able to address breathlessness and anxiety is a really important part of this framework. So we have a framework that looks at the dependency of the patient and how we withdraw non-invasive ventilation to make sure patients are comfortable and dignified at the end of their life. So level 1, as Mary said, is the patient that uses the NIV intermittently. Everybody who's breathless should be on a regular dose of morphine, and only a tiny dose of morphine is ever required. Morphine is the gold standard for management of this, but we also include an anxiolytic, so something like lorazepam into the mix to take away that sensation of anxiety or panic. If the patient needed a longer acting benzo, we would use clonazepam. We've got the doses here on the framework, but they are a guideline and they're not a rule. They are starting doses, and every patient might need something differently. So when we start regular morphine, we start a regular anxiolytic, and those symptoms are not well controlled, then we would change our plan. We would increase the medicines, or we would consider starting a syringe driver. Often the syringe driver is a really good way of maintaining a regular anxiolytic and a regular opiate in that patient. Once the patient is comfortable, we're able to remove the NIV and replace that with equivalent FiO2. I need to stress that it's really important that the patient gets the same amount of oxygen. Patients report to us that they feel like they are suffocating, that they feel like their heads are being pushed underwater. when they're breathless. For level 2 patients who are using it most of the day and night, the plan is the same. We use regular opiates, we use regular anxiolytics. Sometimes we need to progress if the symptoms are not well controlled and increase those doses again and add in a subcutaneous infusion of both midazolam and morphine. For level 3 patients, so these are the patients that are dependent 24 hours a day, they may again need higher doses of morphine and anxiolytics in this setting, and again may need syringe driver as well with a combined dose of medicines. But we need to remember that sometimes we can't get these patients off non-invasive ventilation, and sometimes they actually die on NIV, and that's okay as long as they're comfortable. There are really important points to consider when we're looking at those patients who are completely NIV dependent. We really aim to avoid removing the NIV after hours or on weekends. If it's unavoidable, we contact the palliative care specialist on call. It's really ideal to have a specialist palliative care nurse or a really experienced respiratory nurse present, just in case things don't go as well as we hope. We always make sure we preload the patient with medicine so that they're very comfortable before we make any changes. We check their level of responsiveness. If the patient's non-responsive or very drowsy, then it's okay to proceed. High flow has become a little bit more prevalent in recent days, and I think Mary is going to speak to that.
So with high flow, we saw it in the last, there was an explosion of high flow, and often in the pulmonary fibrosis patients. So with high flow, the PEEP is what's supporting it, supporting the functional residual capacity, improving oxygenation, and the FiO2 is whatever FiO2 they need. So when you get to a level of 35 litres or less, you're no longer delivering PEEP. So we aim to reduce the flow. So say the patient's on 70 litres of flow and 100% oxygen, hopefully they're not, we reduce the flow rate by 5 litres incrementally at an hour at a time. We don't touch the FiO2 because that's the amount of oxygen they need. And sometimes we'll never get them off the high flow altogether because they're too distinct. So we wean at 5 centimetres at a time, and if the patient's comfortable with the medications on board, then an hour later we wean at another 5 litres of the flow until we get to a level of 35 litres. Then we take it off and put them on the equivalent oxygen. So if they're on 50%, they'll get a Hudson mask. If they're on 36%, they'll get 4 litres nasal prongs. What we don't do is have them on 80% oxygen and put them on nasal prongs 2 litres because it's just like drowning them. Okay, sorry, keep going. Yeah, sorry. Right, okay, that's the flow, that's the high flow weaning process that we can also give you. It's very similar. Yeah. Do you want to say anything to that?
Yeah, we have little cards that we can hand out that actually guide you in terms of what oxygen requirements mean what mask. So post-development of the framework, we wanted to look at the level of dependency of withdrawal to make sure that our patients had good symptom management at the end of life.
We had 81 patients, the mean age was 76.3 and 63% of them were male. What we found was significant fewer patients had agitation at death, with only 14% reported. Fewer patients with dyspnea and anxiety at death. Results didn't meet significance, but there was a better outcome for patients. 71.6% of all patients were withdrawn from non-invasive ventilation within 24 hours, and 78% by the time of death. The group still on NIV were primarily high flow who could not be weaned off. Level of dependency at commencement of withdrawal, and you can see it improved. The last group is the high flow group that there were more patients on in the later death. Identified burden symptoms at time of death. So no agitation at time of death, it improved. No anxiety at time of death, it improved. And no dyspnea at time of death, it improved. And that's what's important to our patients. This is the memories the families have of them, and you don't want any patient to suffer. Usually we've looked after these patients for 20 years. Oxygen support at time of death. Non-invasive ventilation changed to equivalent oxygen. or a high flow or nasal prongs or Hudson mask at time of death, improvement. Spontaneous and CPAP ventilation maintained, unable to wean off, there was improvement, and the high flow maintained until death despite weaning the high flow group we couldn't get off. Next.
So we learned a lot of things along the way, big surprise. Basically, we are out of time, the sign says, but I'm going to finish it with a burst for Mary Lafferty. So we knew that the benzodoses we used were too small. Our patients were not sedated enough. We needed to improve those. We knew that clinicians were transitioning to little oxygen and the patients were breathless. We know that family think NIV maintains life, but it doesn't, and we all know patients can die on NIV. We know that patients don't necessarily die quickly and they can live hours or days after withdrawal of NIV. So it's really important to manage those respiratory symptoms with good medicines. And remember, if you're using a complex machine, which is called a D60, I have no idea, many of them have a minimum backup rate, so it's important to look at that.
Change them to another machine and turn the backup rate.
This slide tells us that basically we're seeing more and more patients on high flow now rather than NIV. Their symptoms are the same. We need to manage them well with benzos. We know that implementation of this framework has increased consistency of how we withdraw it. We know that it's improved end-of-life care for patients who are breathless and frightened, and their family are frightened as well. Our next step is really to validate our tool further by looking at a group of independent palliative care specialists and to also do a multi-site evaluation of our tool. And our take-home message, and sorry for going over time, is that really patients must have regular NPRN opiates, they must have regular NPRN benzos, and the oxygen that we convert them to really needs to be the same. There are no ethical considerations around this that cause us any distress when we look at withdrawing non-invasive ventilation. And do you have any questions?
Excellent. It's amazing how much you can cover in 12 minutes. We're all learning to talk very fast. Thank you for that very important and very thought-provoking presentation as well. Does anybody have any questions for Linda or Mary? No? Okay. I will let you both go.
Thank you for your time.
Breathe. Take a deep breath. Thank you both. I do, for those of us that aren't very clinical anymore, which is for the betterment of the patients, but for those of us who don't have a lot of hands-on anymore with patients, it is always really refreshing to see presentations like this that often remind us of how we make such a difference in the care journey of our patients and the experience of their family, friends, carers and loved ones. So it's an absolute credit not only to Linda, Mary and Mary, but to all of you who have presented today. And never underestimate the contribution that you make. I think so much of today has really reminded us around what we do and how much we do contribute to person-centred care, perhaps even without always realising it. So on that note, we shall head off to lunch. But before you do, please make sure that you use the lunchtime not only to eat, but also to vote on our posters, because there's a terrific number of posters that are really worthy of your review and your voting. So if you can please take some time to make sure you do that. And we are scheduled to return at 2:20. We are bang on time, so enjoy your break and we will see you later.
I hope you enjoyed lunch. Our catering has come from a local company, A Plated Affair, and I think they did an incredible job on the catering today, so an acknowledgement to them. So we're on the home stretch. We have a big session to finish the afternoon before we present our winners of presentations and posters. And before I invite our session chair up, I would like to let you know that this session is audience choice. So we have 2 awards to present in this session, and at the end of the session we will display a QR code on the screen for you to vote for your top 2 presentations from this afternoon's session. If you don't have a device, that registers QR codes. You can... Sound online is quite poor. Okay, let's turn that. All right, we're at full speed. Wonderful. So there'll be a QR code displayed at the end of the session. You'll have about 5 minutes or so. For those without a QR code registering device, if there's anyone, borrow one off a friend or put your hand up, you can use my phone. After this session, we will move into our presentation of winners or posters and presentations across the session today. And our wonderful guardian this afternoon and session chair is Karen Takiri, Director of Nursing, Prince of Wales Hospital. If you could join me in welcoming Karen for the session.
I've got a hard act to follow with my peers before me, but I'm on the home stretch, so I hope that you bear with me. So, as Dan said, I'm Karen, the Director of Nursing at Prince of Wales, and it's an absolute privileged role that I have to be able to advocate for the nurses across Prince of Wales and Sydney Eye. But it's days like this that bring me absolute joy. And looking around the room and listening to the presenters, I realise how many I've had a connection with over a number of years. And it's fabulous to see the work that we can come together as nurses and midwives and collectively share our learning, our expertise, our wisdom and our passion. And that's what gives me absolute professional joy. And I want to congratulate all of the speakers this morning. So this afternoon we've got 6 presentations, and we're going to start by inviting Sarah Williams to come forward. Sarah is our Advanced Care Planning Clinical Nurse Consultant at Prince of Wales, and Sarah's going to talk to us and present on the nurse's role in shared decision-making in palliative care, an integrative review that she has completed. Her presentation, I feel, will provide invaluable insight into the critical role nurses play in facilitating shared decision-making in palliative care settings. Please join me in welcoming Sarah.
Can you hear me well? Thank you. I'm pleased to share my review. As you can see, nurses' role in shared decision-making in palliative care in integrity review. About 3 years ago, I started attending family meetings to discuss whether to continue active treatment or comfort care. These meetings were mostly likely led by geriatricians, but nurses had a valuable insight for patients, but they did not say much. Then during that time, and I asked myself, why were nurses more involved? That question just stayed with me for a while, and then inspired me in this review. This review is aligned with highlighted areas, particularly developing person-centered cultures. Let me give you a bit of the background. Shared decision-making is a collaborative process where healthcare professionals and the patients make decisions together. The balancing clinical evidence and expertise with what matters most to the patient, such as values, beliefs, and preferences. In palliative care, this process is more critical. These conversations often very difficult choices whether to pursue life-prolonging treatment or move towards comfort care. Although nurses are well placed to support these discussions through their close relationship with patients, there is limited research exploring their role in bridging communication between patients, families, and across healthcare team. So this review offers the insight how nurses participate in decision-making process and how their involvement and contribute to more person-centeredness in palliative care. The aim of this review was to synthesize published research on nurses' involvement in person-centered and shared decision-making in palliative care practice. So to look into this, I carried out integrity review with using systematic approach guided by Whitemore and Knight's framework. So this is the framework, includes 5 stages. You can see the 5-stage process, starting from these finding problems, literature search, data evaluations, and analysis and synthesis of the findings. The literature search was conducted across a database including CINAHL, PubMed, Scopus, and EBSCO for articles published between 2019 and 2024. I included peer review, primary research, and involving adult palliative care patients in hospital settings. The study involved intensive care, mental health, and psychiatric populations were excluded due to the unique decision-making challenges on those groups. Now, as you can see the prisma, the diagram, that the selection process narrowed down from top to the final 13 studies. Initially, I found 364 that I identified, the additional 5 as through citation checking. Duplicate removed, title and abstract screen, and title assessed for eligibility. The 9 studies excluded with these revisions because not meet this exclusion criteria. And finally, I had certain studies included for this review. There is a certain studies were conducted in Netherlands, United States, UK, and Australia. With sample size from 5 to 179 participants. And total of 861 participants were included. The studies covers a range of experience from cancer patient and nurse-patient relationship in oncology, and end-of-life care patient with heart failure, kidney failure, and those undergoing dialysis. The findings were synthesized with 3 key themes. The first theme focuses on nurses' role in facilitating shared decision-making. Across several studies, nurses were shown to play a critical role in complex palliative care settings where decisions are often emotionally charged and deeply personal. According to Sharma and colleagues, 90% of patients felt more informed and involved in their decisions when nurses actively engage. This aligns with the person-centered practice framework by McCormack and McCann, which highlights this importance of building therapeutic relationship, engage authentically, and respecting individual values as core to person-centered care. Nurses are constant presence, emotional support, and ability to build trust that helps patients feel safe, understood, and actively involved in their care. When nurses are involved meaningfully, the study reported increased patient satisfaction, reduced decisional conflict, and better alignment with patient values, the key outcome of the person-centered nursing practice. The second thing about the barriers. This is where the gap between ideal person-centered care and clinical reality becomes clear. Time pressure was one of the biggest challenges. In many studies, nurses were overwhelmed with clinical tasks, the limited time for meaningful conversation with the patient. This made it harder to explore patient values in depth, which can impact how well treatment decisions align with what really matters to the patient. Next, hierarchical team structures also undermine person-centeredness. When nurses are excluded from key decision-making conversations, patients miss out on the advocacy and emotional insight that nurses are uniquely positioned to provide. A lack of the role clarity was another key barrier. The nurses often not sure what their contribution should be, or didn't feel their input was valued. Without a clear role clarity, it is hard for nurses engage authentically and advocate confidentially. Lastly, insufficiency of the training left many nurses the feeling underprepared. Even when they are willing to be involved, many nurses lack the confidence to engage in sensitive end-of-life conversations. This means that there are limited opportunity to provide care that truly reflect patient voice, values, and dignity. The third theme focuses on what needs to change. These themes highlight clear strategies for strengthening person-centered care practice. Target education and training significantly boosted nurses' confidence by developing their ability to engage meaningfully, listen attentively, and support patients in expressing what matters most. Strong communication skills were also emphasized, particularly the navigate emotionally complex conversations. When nurses are equipped for these discussions, the result is not only better decisions, but better person-centered care. Several studies also underscore the need for decision-making tools tailored for nurses. Countries like UK and United States have introduced nurse-focused models, such as shared governance model or shared approach, that have shown promising outcomes. However, in Australia, there remains a gap. We still lack nationally recognized structural tools to support nurses in guiding these critical conversations. Moving forward, it's not just about removing barriers. It's about building a culture where nurses are empowered to take an active role in care decisions, making person-centered outcomes not just possible, but the standard in palliative care. In conclusion, these reviews highlight three key messages that are strongly linked to person-centered nursing practice in palliative care. The first, addressing barriers is essential. This includes providing target education, clearly defining the nurse's role within multidisciplinary teams, and equipping nurses with practical tools that support value-based communication. Growing efforts show that when nurses are meaningfully engaged in decision-making, person-centered care is strengthened through trust, therapeutic relationships, advocacy for what truly matters to the patient. And finally, the future research should focus on better integrating nurses into decision-making process across healthcare teams. This will be key to shaping more cohesive and person-centered cultures in palliative care. Thank you.
Any questions?
Any questions?
Yes.
Oh, yeah.
Sarah, thank you for the presentation. I'm just curious because there were a lot of themes that came up from your presentation. Just wonder what processes, how did you come up with all those themes?
I like your questions. To determine themes, I use literature matrix. So you can actually download from Google. So I make simple, simple table. So, this case is 13 primary studies, so 13 lines. So all the, demographic of these research and the key findings, main concepts, main ideas. Then I type it, all the typing. Once finished, I look at the, the typing of, the key items or main concept, and then I can see find the similarity. If you see a similar the ideas, I color the same color. Then another one different color. Once my color coding finished, when they're looking, I can put some same groups. Once put them in grouping, able to define these the themes. But most importantly, the themes has to be direct links to my research questions. Sometimes the finding is very good, excited, but away from my research question is not good. So always is the themes direct to my research questions. Thank you.
Sarah, any other questions? I have one for you. So you started your presentation by talking about your lived experience of sitting in family meetings, MDT meetings, and noticing that nurses were quiet when these decisions were being discussed and talked with the patient. And now you've got all of your data through your review. Were there any surprises from your lived experience to what the literature was telling you?
So actually when I started, I didn't get any training or in service. I just jumped in. So it was very difficult. So when I'm looking at this research review, and then lack of training, it's a very similar things. But the one of the biggest surprise was other countries, they already started nurses, so tailored to nurses shared decision tools. Australia was so behind. That was really, really so behind. And really we need to urgently look into the tools designed for nurses. So nurses confidently, with his strong knowledge and looking at the patient with his dignity, values, and their preferences. So we have a lot of work to do to move forward.
Thank you, Sarah. Thank you for a great presentation. Next, I would like to invite Jodie Bancroft, Nurse Manager, Leadership, Education and Development from St George, and Jane Lewis, Nurse Educator Model of Care Project Lead from St George, who are here to present Empowering Nurses and Midwives, the St George Models of Care Project.
And thanks for the opportunity to showcase the work of the 22 wards that we have involved currently in our models of care work here at St George Hospital. The project couldn't be possible without the sound leadership of our Dom Lauren Sturgis, and also without the Nurse Strategy Reserve funding and the support from the District Nursing Midwifery Practice and Workforce Unit, which has enabled us to keep Jane's position for the last 15 months. So that's very exciting and really impacted the way that we were able to roll out this project and embed it into our current ways of working at St George Hospital. So in terms of our wonderful strategy, well, the Models of Care project, like a lot of the other presentations, covers across quite a few of the strategic actions. I suppose the one that resonates most with us was developing person-centred cultures. And the way we look at it is that what we're aiming to achieve is to utilise dedicated time to enable staff voice and create individualised models of care, to foster innovative initiatives that engage and support staff in providing safe, high-quality person-centred care, and enhances collaboration within and across teams across the hospital to foster a shared vision and collective decision-making, and incorporating flexible care approaches to cultivating a more adaptable and supportive workforce, which we hope is resulting in increased job satisfaction and wellbeing for our staff. So where do we come from? Why did we decide to do this work? Well, like many of us after COVID in 2023, we found ourselves in a situation we hadn't been in for quite some time, with a depleted workforce, with increased junior staff that felt really unsupported. We had preceptor fatigue and some acuity challenges that we really couldn't overcome, and issues with burnout, workloads, reduced job satisfaction, reduced wellbeing, and really what staff were saying is they believe that this was contributing to poorer patient outcomes. This was supported by our People Matters survey feedback and feedback from not just our clinical staff but our executive teams throughout that. So we thought this was a really good place to start, that we needed to have a look at the ways we were working, to work within our teams who are great at finding solutions, and chat to them about how we could improve the way we were providing our care at St George Hospital. So the aim of the project, well, we wanted to address themes, as I said, in a way that was person-centred but staff-led. So we previously had been using a productive ward model, which really put the staff at key at making decisions about how they were going to implement changes in their workplace. So we wanted to build on this foundation to really engage the staff moving forward. So our aim was to enable and empower the staff with the skills and ability to create team models of care that were flexible and adaptable depending on the staffing, the skill mix on the day, and the acuity, which we know is different shift to shift, day to day. So we didn't want a model of care on today's morning shift that looked the same as tomorrow's afternoon shift, with differing staff and skill mix and differing patient acuity. I'm going to head over to Jane to talk about methods.
So how did we do it? Well, the first phase of the project was the data collection. So the model of care team, I'd like to acknowledge Katrina Eisenhower here and Meg Cummins also, who were part of the team, conducted some site visits to hospitals outside our district to actually have a look and ascertain some benchmarking and look at what models of care elsewhere were and how they were working. So we engaged 22 wards, as Jodie said, across the hospital and asked staff to complete the survey. So we developed a survey looking at 5 key indicators around team models. We looked at role clarity, the team model, leadership, communication and team culture. And we ascertained a 75% response rate, which was outstanding, so I'm led to believe. We had 6 wards that had 100% response rate. So we then moved into the planning phase of the project, and we shared all the data from the survey with the staff and the leadership teams and facilitated focus groups with each of our areas. We conducted the focus groups weekly for the first 3 months of the project, fortnightly for the next 3 months, and then monthly into the sustainability phase, which is where we're sitting. So over the last 15 months, we conducted over 400 facilitated focus groups with our staff. So it was a great opportunity for staff to be able to have a voice and to be able to present any challenges that they were experiencing in the workplace. So during this phase, we utilised multiple different tools: process mapping, circle of influence, circle of concern, appreciative inquiry, to actually get the staff to actually identify what their challenges were and for them to adapt a personalised model of care for their ward. From that, the staff actually actioned an action plan, and then we moved into the action phase of the project. So the date was set to go live with the proposed changes to their new models of care. And as Jodie said, each ward was an individual plan that they had put together. They came up with the solutions. It wasn't me telling them what they needed to be doing. So throughout this phase, it was really important that we engage those QI leads. So they were the ones, along with the leadership team and with our support, that were driving those changes throughout the project. We had monthly catch-ups with the QI leads just to ensure that they were on track. We also had monthly catch-ups with the leadership teams, and that was done by MS Teams, and it was an opportunity for them to share their successes and also share any of the challenges that they were experiencing. And it became quite evident through those groups that a lot of the problems were hospital-wide. We also had engagement with our divisional directors and clinical services managers. So we were meeting with them on a regular basis and escalating any concerns or any roadblocks that we had throughout the project. So if we had lack of engagement, we would meeting with those divisional directors, so it was the top-down, bottom-up approach, which was really supportive for us within the project. It was the main agenda on everyone's lips. We also had the Director of Nursing and the executive team do walkarounds. So throughout the hospital, we had 22 wards participating. We actually did hospital walkarounds with the executives so that they were able to see the progress and also listen to some of the other concerns that staff were raising. As we moved into the evaluation phase, due to the funding of my position, we probably did our evaluation, we call it a mid-evaluation because we will look to do some further evaluation at the 12-month point. But because of my funding, we did do an evaluation just to see where we were at. And we had another amazing 68% response rate with that survey. The results didn't show any real statistical difference. In hindsight, some of the areas, because it was a bit of a trial and error with some of the changes that they'd implemented, some of the wards had only implemented those changes 8 to 12 weeks ago. And as we know, change management takes time and change culture is an ongoing process. However, the qualitative data that we were getting from the focus groups that we were having was showing that staff were reporting they feel more supported, they're getting to their breaks, they're going home on time. So this was all really positive feedback that we were seeing. We're currently sitting in the sustainability phase of the project, and whilst keeping in mind that we did commence this as a project, we really want to now embed these new models of care to our business as usual. And I think the key to the success of this is engaging those QI leads and the leadership so that we can continue to drive the changes. So as with any project, there's always challenges. So I guess one of the biggest challenges for us was the pure scale of the project. We met with, as I said, we did the site visits. Another site had done a project very similar to this, that they rolled it out across 4 wards and done 1 ward over 3 months. And we were aiming to do 22 wards altogether. We're also challenging the current norms. So we wanted the teams to engage in that team nursing model of care. And when we got down to it and drilled down a little bit further, staff felt that they were team nursing, but when we actually drilled down, true team nursing was not occurring and staff were not feeling like they were supported. So challenging that and getting the staff to see that they needed to make some changes. Change management, as I mentioned earlier, and lack of engagement. We did notice throughout the project that the areas that had a strong leadership team with the NUM, the CNE, CME, really had positive change, and they also had involvement from their clinical nurse or clinical midwife consultants that were really driving the project. Areas that had change in their leadership really saw some not so positive results, and we actually had to pause and consider where do we go from here. So how did we address some of the challenges? We listened to the feedback, so when we were meeting weekly, we could address that feedback in the moment. We're acknowledging the failures and going back to basics. So giving people time to actually pause, reflect, okay, where do we go from now? And also, as I mentioned earlier, escalating any of those roadblocks to our executive. I'll let Jodie talk about the successes.
Thanks. So the key successes, I suppose the things that surprised us, and that question that you asked before, Karen, I thought about it, and I think the things that surprised us really was the engagement of the staff. At the beginning, we thought, how are we going to get people to fill out a survey, and let alone having 6 wards with 100%. So the engagement and voice that staff felt that they could have really came about through the involvement in the focus groups and the staff ability to speak up. So they were speaking up at the focus groups, but actually speaking up and saying, hey, that model of care is not great. Just because you guys worked together yesterday, the world looks very different today. Can we have a look at that and can we have a discussion about that? So what we found was how quickly voice and people were able to speak up was probably a key success from this. Stakeholder engagement, always important with the project, and as James was saying, is our way of working moving forward. But having everybody on the same page, and different boards use different methods to actually disseminate that information throughout their staff. So some of them have got WhatsApp groups, Facebook groups, emails, but making sure that everybody was on the same page, that this was how we were going to work, and we worked together and these were our solutions, was absolutely pivotal to the success of those teams. And look, I suppose one of the things we might not get a chance to talk about was the out-of-scope work, and that was one of our key successes. So at the beginning, these issues kept coming up about scopes of practice, of AINs, about time away from the bedside, with delivery sandwiches to help from, and our relationships with health share, with pharmacy deliveries. We tried to park it and say, oh, that's outside the scope of the project, but when we did that, staff were getting quite frustrated, and we could sense the frustration. So what we actually did is we took it on outside the project, so the wards would give us the feedback. Jane and our NESM actually took that part on board and started addressing some of those issues that we had planned to address as part of the project, but we thought were really crucial, and those successes of that out-of-scope work was really part of what enabled staff engagement. They could see change happening, they could see that we're invested in it, and that the time was invested into making, I suppose, some real differences in those changes. So that's just some of the out-of-scope work. And in terms of future potential, well, we feel it's got a lot of future potential, this project. We really enjoyed engaging with staff and listening to what the feedback was from the staff. The feedback we're getting now from our focus groups, from our AINs who aren't floating, who are team nursing, is that they feel well supported, they feel valued, they're going home on time, we're getting people to breaks. One of our big things, especially in the midwifery frame, that real women-centred care, was enabling staff to actually get away to break. So we've made some breakthroughs in those areas, so we feel very blessed for that. Educators are feeling less overwhelmed and less that their workload is under control. And really, above all, staff feel the confidence to speak up. So we really feel that this is something that we can roll out, on our few remaining wards, and then, feel like it's got potential across the district. And that's just a few of our quotes from some of our staff. That photo.
My photo here is at the end of last year to celebrate all the success, and we wanted staff to reflect and actually think where they had come from to where they are now. So we asked them to create a year in review poster, and this is just us celebrating with the executive, all the QI leads, the staff and the leadership teams, celebrating with an afternoon tea to look at the progress and the success they've had with the project. Thank you.
Thank you.
That's a wonderful piece of work, and I think it's a great representation when we talk about person-centred practice. This is what this is. It's about when we have patient, family and staff, and we actually understand their needs and what matters, and this absolutely has given a voice to staff to share how they want to shape their work. So fabulous. I do have time for one question from the audience. Therese.
Ladies, fabulous project. A lot of focus groups, a lot of work. So my question is and it's related to, you said there was a lot of flexibility with the models of care that came about, and each of those would change and evolve on a different day. Did you find any, I suppose, how did the staff, what was the mechanisms internally for the staff then to be able to identify that they needed a change in the different model every day? And my second part, which is probably a sub-question or another question, is there any synergy between the different models across all of those areas that you worked, the project was involved?
Yeah, so I think the second part of the question, what we did, we collaborated, as Joan was saying, once a month we got together, and the sharing of ideas, absolutely true. So one of the things was about having teams within teams and what that looked like, and a model of a team of 3 was something that came up. So these guys were looking after 12 patients between the 3 of them. So that model has definitely been something before the project we ever did, that is something that a lot of the wards have actually taken up. They had challenges with that, and so they had to come up with how are they going to overcome those challenges, and things like an A3 team working guide, where they actually rounded back every hour to where they were at, or more often, but that was a minimum. They also had like a team planner that they worked on. So that was something that definitely we saw started in one area and moved across others. The other one is the traffic light system you would have seen here that we had up on here, which was something that you're probably best to talk about that, Jane, but another project that went across the hospital.
So one of our wards in particular found it really challenging when they were stuck in their high observation room. So when they implemented their team of 3, they found that one person was still getting stuck in that high observation room. So they developed, or one of the wards, 6B I think, developed this communication patient safety tool, I guess, which is a traffic light system. So if the light is on red, that means someone needs to be in there at all times. If it's on amber, it's frequent sight. If it's green, all is bright. So the staff at the beginning of their shift will identify what patients are in that area and set the traffic light, and then they will communicate between the team and move in and out. But if it's red, they will make sure someone's in there at all times, but they're still moving within the team on the ward.
That is the first part of that question. Just, yeah. And so about the adaptability, I think, and so they had a few different ways that they could model their care, and so today we might model it like this because this is the acuity that we've got, but it wasn't strict, it wasn't set. So what was happening on one ward wasn't the same even if one's got a 24-bed base and the other one's got a 30.
So I think the biggest thing with that is staff are now feeling they have a voice to say that allocation is not going to work today. 2 senior staff over here and you've got 2 new grads over here. The acuity in this area is far heavier. Staff are feeling that they are actually able now to speak up to that and to have a voice.
And that's what I was just going to comment, that from what you're,
from what you're describing, which is, that's a fantastic example, so that we can really have greater insight to the depth of the project. And clearly you can see that there is that flexibility and the staff have ownership and having a say, which then obviously improves culture, and that there's greater accountability for each individual, and that they're working collaboratively and they're deciding based on the presentations that they have about what that's going to look like. So it's fabulous.
That's all right. Thanks, Ruth.
So can I just congratulate Jane and Jodie, Lauren and the nursing midwifery leaders across St George, because the one thing when you know there's a problem or something not right and you press the pause button, it takes courage as leaders to allow over 400 groups to run, to really hear the voices of nurses and midwives across your organisation and then be prepared to act on it. So well done. It's courageous leadership in action, and it's very, very impressive.
Thank you.
To ask Jed Young and Rosanna Stokes to come forward. Jed is our nursing unit manager of our Haematology Oncology Data Centre, and Rosanna is our orthopaedic nursing unit manager from Prince of Wales, and they're here to talk to you about nursing making an impact. And I note the colour coordination, note the logo, note the jacket, we're very coordinated.
Hello everyone, thanks Karen. So our presentation today is about nurses making an impact using digital health to influence practice. And impact means implementing and measuring person-centeredness using an app for knowledge transfer. I'd like to start with a patient story that we captured through Impact. This was captured by Katrina and Molly, the Impact leads for HRDC. This patient said, I never felt at any point that I was afraid or had fear. I just found everyone really warm and kind to me. There's just a general sense of warmth here. It's helped me feel relaxed and very comfortable when I'm receiving my treatment, as I know I'm in very good hands. The Impact aligns to all of the strategic, relates to all these priority areas, especially in the areas of developing person-centered cultures, enhancing digital informatics and new technologies, and delivering high-quality, safe, person-centered care. I'll talk about the KPIs on the next slide, but this just shows how the KPIs can be mapped to the person-centered practice framework by McCann and McCormack. This framework, developed over 2 decades of research, provides a theoretical lens through which the KPIs can be understood. Each of the KPIs aligns with various person-centered prerequisites identified in the framework. So just a bit of a history of impact. So the current impact study builds on 15 years of research undertaken to develop and identify and implement key performance indicators for nurses and midwives. So the countries involved in this current project include Australia and the UK. And it commenced at Prince of Wales as a feasibility study on the respiratory and infectious diseases unit and the community assessment unit. It was further implemented across 8 units by the end of 2024, so our 2 units are included in those, and envisioned to be implemented in 30 units in total at Prince of Wales by June of this year. So that encompasses the inpatient, outpatient, virtual health settings. And impact is now being offered and implemented district-wide. I'd like to take this opportunity to acknowledge Professor Tanya McCann, Professor Val Wilson, Karen Takiri, and the NAMO Nurse Strategy Research. So as I said earlier, impact means implementing and measuring person-centeredness using an app for knowledge transfer. It is an app that supports the implementation and measurement of 8 person-centered key performance indicators. And the 8 KPIs are as follows. First is the consistent delivery of nursing care against an identified need. Second is the patient's confidence in knowledge and skills of the nurse. Third is the patient's sense of safety while under the care of the nurse. Fourth is the patient's involvement in decision-making about the nursing care. Fifth is the time spent by nurses with the patient. Sixth is the respect from the nurse for the patient's preference and choice. Seventh is the nurse's support for patients to care for themselves where appropriate. And lastly, the nurse's understanding of what is important to the patient and their family. So nursing and midwifery teams can use this app in gathering data to make improvements that enhance the experience of care for patients, families, and staff. There are 4 measurement tools used in the data collection that runs over a 6-week cycle. And utilizing the data generated by the app has resulted in increased person-centeredness amongst the staff and changes to the practice and culture within those units. So why do we use person-centered KPIs? First, we know that evidence is the foundation of any quality and safety improvement initiative. However, the success of that evidence depends not just on what we collect, but how meaningful it is to those engaged in improving practice. We already have an abundance of data sources providing evidence of nursing practice and care delivery, such as our audits or incident reports. But most of these traditional sources of nursing evidence focus on problems like our medication errors or pressure injuries. And there's little evidence gathered that highlights the positive contribution nurses make to patient care. This is where person-centered KPIs are valuable, as it provides holistic evidence about what nurses contribute to the care experience. So let's look into those 4 measurement tools. So first, we take 20 patient care surveys that are collected pre-discharge. This comprises of 8 questions that patients can complete in under 1 to 2 minutes. We then collect 3 patient stories, and so we record patients speaking about their experience of care, and a transcript is then tagged to the different KPIs and whether it's a positive or negative experience. We also look at 10 document reviews to assess consistency between staff views and patients' notes on the important aspects of care. Then lastly, we do 3 30-minute sessions of observations of practice, and that's to capture the time spent by nurses and midwives with the patients. And that's just an overview of what the dashboard of the app looks like. So it tells you how far along are you into the cycle and how many data has been collected. Oh, sorry. So how we implemented it in our unit. So first we had an initial meeting with an external facilitator. So Mary Mulcahy is the project lead for Prince of Wales, one in the middle of that photo. She met with our NUMs to discuss what the project is going to be. We then recruited our impact leads, which consists of RNs and ENs within the unit. We then trained those leads on how to navigate the app. We then presented that project to our units and we started the cycle. I mean, within those 6 weeks, there have been regular check-ins between the NUM, the leads, and the external facilitator. I'll hand over to Rosalie, who can show us the results.
Thank you, Jed. So as mentioned, one of the benefits of the Impact app is the quantitative and qualitative data that the project provides. Within 2 weeks of completing the project, each unit is provided with numerical data and patient excerpts related to each KPI. This data can be easily reviewed to see areas of acceleration and improvement. On these slides, we have compiled quantitative data for both the HODC and 5 SAF units. Almost all patient stories demonstrate a positive correlation with each KPI. KPI 6, respect from the nurse, the patient's preference and choice did not get flagged or identified during the stories, and there was no negative comments against any KPIs.
In the patient surveys, patients stated that at least 80% of the time they always felt that the KPIs were met, and no patient said that the KPIs were never met. The 30-minute observations demonstrated a minimum of 70 of the 90 minutes had nursing presence, which reflects approximately 7 minutes within each 30-minute period that the patient would not have had a nurse in their line of sight. The documentation reviews identified an overall compliance with KPIs 1, consistent delivery of nursing care against identified patient needs, and KPI 8, with nurses' understanding of what is important to patient and family. Following the compilation of the results, each NUM met with the external facilitator and then organised a town to meet with impact leads. During the second meeting, an action plan was developed to highlight areas of improvement. The action plan was then presented at the board meeting. An example of an action plan included documenting nursing notes and goal setting on patient bedside communication boards. To achieve these goals, staff education was held with the promotion of person-centred mindset. We attended monthly audits, reviewing compliance. There were daily reminders and paddles. The action plan was displayed on the quality and safety board, and there was implementation of the bedside communication boards. Also to note, it's also suggested that the impact project is recompleted 6 to 12 months' time of the initial project. An example of the adoption of person-centred goal setting and note writing is demonstrated in excerpts from the HODC unit. Francisco and Maria are going back to Chile for 10 weeks after next treatment, which they're looking forward to, and that the patient celebrated his 90th birthday next week. Surprise birthday party, lots of family members he hadn't seen in a long time, had a very good time. So in a review of the Impact App project, there are numerous positive aspects as well as areas of improvement. The app is easy to use and requires minimal technological experience for both staff and patients. The project was able to be effortlessly adopted throughout the hospital, with numerous units having completed or commenced the project. The sharing of positive patient stories with the unit assisted in maintaining momentum and staff engagement. The support from the external facilitator throughout each stage of the project was valuable in meeting targets and on-hand support. The required tasks of the project were achievable, and there was a minimum increase in the workload of the leads. The project was led by the NUM, which worked well to engage and motivate the team. Some challenges of the Impact project include both the use of the app and completing the tasks. Patient surveys were completed for patients discharged the same day, so depending on the day, they were limited to appropriate patients. Although all in all, there was not a significant increase in the workload, the 30 observations were at times hard to achieve. The success of the project is dependent on the leads involved, including their availability during the project and their ability to complete tasks independently after hours. The information gathered in the patient stories is also dependent on the ability of the lead to ask the most appropriate questions and to tag the relevant KPIs. A limitation of the app itself is that it currently is only in English, and therefore there are limitations in having all patients complete surveys and patient stories. Our recommendations for areas looking at completing the Impact project are to be mindful in the selection of leads. For instance, I found the use of our educator assisted with the adoption of the project and completing the 30-minute observations. We encourage units to share patient stories and positive feedback received during the project with the team to both maintain momentum, celebrate the care provided in the unit, and spread awareness of impact. And we recommend sharing these updates, for instance, in the morning safety huddle, as it provides a time to identify patients that are suitably interviewed, complete surveys, or to document reviews. Additionally, moving forward, we would like to see the app developed to be more inclusive to patients of all language backgrounds, including multi-language option for the survey and possibly an interpreter option with the patient stories. To finish, we would like to share a patient story captured on 5 South. This is a lovely story showing the patient's appreciation for the nursing care they received. It shows the confidence the patient had with the staff and the communication about her needs and care. So I've had a very good experience here as a patient. All the nurses have been very helpful. I've had a shower every day and have been given a lot of positivity from the nurses, which has really encouraged me. They answer my buzzer really quickly and they give me tea and coffee when I ask. They help me when I need to go to the toilet. Just their attention to detail in terms of how caring and helpful they are. They have been very clear with communication and the plans needed for my care. I feel comfortable and happy to be in hospital. You say I've been a patient here for a long time. The nurses here are so lovely, all of them. They treat me like I'm part of their family. Thank you so much to them all. These are some of the references that have informed the impact study and project. And thank you for your time.
Any questions? So if there's nothing on the floor, I'm going to ask a question. So this is one mechanism of giving patients a voice. But when we've had our governance group, a lot of the NUMs have said this has been one of the most easiest programs of work to implement. Why do you think that is?
I think one part is obviously some of the tools that we use to get feedback from our patients without a care opinion, just spontaneous feedback patients give us from families, the compliments and complaints. Those are tools, they're all in different areas. Whereas with the impact app, you have all that information together, plus just you're constantly hearing like positive sides of things we found, which just brings so much joy to the unit and really solidifies the work that they do within the teams.
That's a great answer. So, our next speaker, I'd like to invite James McVeigh, nurse practitioner from Prince of Wales Hospital, to come forward. Jim is going to talk to us about teleclinical care heart failure, enhancing person-centered care for heart failure patients through remote monitoring. And his presentation will explore the benefits of remote monitoring in managing heart failure patients and improving their care. Thank you, Jim.
Good afternoon. Thank you very much for accepting my paper presentation today. I'm going to present on our teleclinical care. It's a digital platform that we use for our heart failure patients. And this was a sub-study of a bigger study that was done at Prince of Wales Hospital. And the title of the presentation is TCCHF, Enhancing Patient-Centered Care for Patients with Heart Failure Through Remote Monitoring. And at that stage, it was, as a nurse practitioner, is how it made it patient-centered and how it supports delivering care for people primarily in the home. The element of the study is I looked at two subjects of enhanced digital informatics and new technologies and delivering high-quality, safe, patient-centered care. The remote monitoring program is humanised by the care that is delivered by the nurse practitioner and now nurse practitioners at our institution. We provide individualised care through communication on our modes of delivery, through telephone and home visiting, and knowing that the patients and the patient-related needs are met. In doing so, we provide shared care decision and negotiation what works for the patient. So, heart failure has a significant burden on the Australian population. This is some statistics that was put together in 2017 by Chen et al. From Australian Catholic University in Melbourne. And at that stage, it was, take glasses off. At that stage, it was found that there were about over 100,000 people in Australia living with heart failure, 2.1% of the population. They estimated by 2025, which is now, that would increase by another 50,000. It's related to have 158,000 admissions per year to hospital, with a quite significant mortality of about 61,000 people death per year. And as a result of the utilisation of acute care capacity and that presentation to general practice, it's a very costly condition to manage at about $3.1 billion in healthcare. They also looked at it from a state point of view, and in New South Wales, the numbers were about 169,000 cases per year, with about $1 billion in healthcare costs. More recently, in terms of remote monitoring, they scoped about the heart failure burden in our local district, and they said about 1,000 hospitalizations per year with heart failure, 1,000 patient hospitalizations. So teleclinical care heart failure, TCCHF, as its acronym, was a teleclinical care using a smart device, either a phone or an iPad, that had an app on the device that provided remote monitoring using Bluetooth-enabled peripheral devices, which were a sphygmomanometer, weight scales, and an oximeter. We also provided a symptom questionnaire, and what this allowed was early detection of decompensation, but it also allowed for clinical management supports required for people who are prescribed therapies in heart failure. It was a single-arm implementation evaluation aimed to describe how remote monitoring can enhance the delivery of patient-centered care and minimise hospitalisation. Participants who possessed or had capacity to use the appropriate smart device were prospectively selected from those already under the care of the nurse practitioner and led heart failure community outreach in Prince of Wales. We enrolled 45 patients, 30 male, 15 female, with a mean age of 75 years. 28 out of 45 had heart failure with reduced ejection fraction. The remainder 17 had heart failure with preserved ejection fraction. This was quite a comorbid population, with 58% with having atrial fibrillation, 51 hypertension, 44 chronic kidney disease, 33 type 2 diabetes, ischemic heart disease 29, and anemia and iron deficiency 27. People with heart failure are often impacted by at least 3 to 5 other comorbidities that does impact capacity to remain well with this chronic condition. The app itself on the phone, as you see here, when it's opened, has capacity, blood pressure, oximetry, and weight. The patients push the start button. It communicates with the blood pressure, weight scales, and the saturation probe. There's also a get help button if they feel unwell at any time. They can push that and it puts further information. And there's notification that does healthy information, and there's also potential to provide them with an exercise regime or prompt them to do exercise. The information that comes back is very helpful in terms of it gives you continuous information on blood pressure, heart rate, weight, and saturation. And what happened was, it was like between flags, we would set certain values, and then if people went outside of those values, it would send an alert through the machine, and then would receive an email to tell us that there was a problem and we could intervene with that problem. The mean follow-up was 211 days from August 2021 to September 2022, right in the middle of COVID. Each alert was assessed by myself to identify abnormal alerts that required a patient-centered approach to early management of signs of decompensated heart failure or abnormalities related to their cardiac condition. There were 338 alerts received in total. 35 of 45 patients, 78%, generated at least one alert. 48 of the alerts, 40%, were deemed required further intervention, 10 for tachycardia, particularly atrial fibrillation, 16 for hypertension, and 20 for weight gain. And even those with atrial fibrillation at home with an elevated heart rate, due to the capacity and scope of practice of the nurse practitioner, I was able to intervene and manage these people at home without requiring hospitalisation. And the weight aspect was often related to fluid retention and gain, facilitating management at the right place at the right time for the right person. The average participant, and this was acceptance. Now this is an age population of 75 plus. People would think it's not for the elderly. Surprisingly, I'll comment on that toward the end. The average participant submitted 0.38 observations per day per device. 31 of 45 were highly competent. Patient satisfaction was very high with 4.55 out of 5. In terms of use of devices, 97.5 reported the blood pressure device and scale easy to use. 90% the pulse oximeter, which is interesting because you have to pop that on your finger. It was more the troubleshooting of the pulse oximeter. The more the troubleshooting of the pulse oximeter, because you pop it on, it can give you any sort of number and then can make a false alert and cold hands and all those things together with this. The outcomes related to hospitalisation was quite interesting. There were 9 hospital admissions observed within the study period for this cohort, compared to 58 hospital admissions for the same cohort in the previous 12-month period. There were 3 deaths, all from non-cardiac causes. We're not saying that this reduces mortality, but there were 3 deaths. We did use the Kansas City questionnaire, and both pre and post there was no difference, and we used the ARM7 questionnaire that supported regarding medication compliance. Again, no statistically significant difference, but a slight improvement for those posts. The clinical application for the clinician, i.e. myself as a nurse practitioner, clinical assessment data with pulse, blood pressure, weight supported individual management plan. It allowed me to intervene with acute decompensation. It also, for people with heart failure, reduced ejection fraction that require enhancement of the pharmacotherapy, we were able to do that in a very safe manner because we were able to see blood pressure and heart rate responses. Both trends and daily measurements were much more accurate information than doing a once-off blood pressure or heart rate. Data alert facilitated early person-centered clinical interventions within the home, subsequently reducing hospital admission. Data surveillance supports individual rapid up titration of guideline-directed therapy, and the patient utilising the system actually provided them with enhanced self-care and empowerment. So in conclusion, TCC-HF was an innovative model of care that enhanced patient-centered practice in real time. Interpretation of remote monitoring data and knowing patient-related needs informed individual treatment and modes of care delivery, either by telephone or prompt home visit. TCC-HF was implemented successfully and well received among this cohort of elderly patients. An early detection of heart failure decompensation through signs and symptoms and individualisation of management plan reduced the readmission and presentation to hospital. In relation to current practice, New South Wales Health are promoting remote patient monitoring as a means to support people with chronic disease. At our own institution, and that may spread across our area, we've got remote patient monitoring heart failure, RPM-HF as its acronym. It's a component of the heart failure model, standard model of care of Prince of Wales now. There have been 212 people monitored within the last few years, and we've got currently 122 actively being supported. It was also not TCC-HF. The principle of TCC was one of the large management strategies through COVID period, and they're now using it for gestational diabetes in Prince of Wales. My acknowledgements for this study must go to the cardiologist at Prince of Wales, Professor Sian Nui, Dr. Green International and Jenny Yu, and the University of New South Wales Biomedical Engineering Department of Professor Nigel Lovell and his team. And in collaboration, they have developed this app and have done the background work. In fact, Nigel Lovell and Brian McLean were doing this in 2001 when I first started at Prince of Wales Hospital. Also like to thank Dr. Charlotte Bannock, who was one of our interns, who supported me in data collection, and Thomas Bradbury from the George Institute. Thank you very much.
Thank you, Jim. We'll just open up to the floor for any questions first. Glenn.
Thanks very much for the presentation, Jim. I suppose just a few questions. Will this, how is it funded? You've got 112 devices, so that's all funded through the blood pressure cuff for
Area Health.
Area Health, yeah. And also, can you see, I can see the reduction in readmission rates is impressive. That's quite startling. But also, could you see utility of this with being used by primary care? So when we're encouraging GPs to uptitrate medications, do you think they would have some benefit in sort of accessing this sort of technology to monitor the response to uptitration?
So general practice have access to the back end for this. At the moment, we we are still struggling to get them engaged in utilising the back end.
Yes,
We also, I certainly encourage people to bring their smart device to them and show them the real ongoing data that might stimulate them to think about what you've just promoted, supporting their care.
Fine, thank you.
I think this is a great example of when we bring together clinicians. We had the biomed from down the road at the university. We all came together, and I remember those initial startup discussions. And our future discussions, as we've evolved now, we partner with the remote monitoring staff in the CMC at Prince of Wales, who are those people watching for flags and triggers, and then you as a practitioner being able to triage and prioritise based on those patterns and trends. I guess what would be your advice to the audience of thinking about using this technology, because a lot of the discussion sometimes is about trust, and how do we build the trust with the technology that there is going to be that human response as well when we need it?
I think we live in a digital era. You can't get up without your phone telling you to get up and move. It's how people come and trusted with it. I think, you know, what I did find is people often say, no, you can't, this won't be used for elderly people. They don't use technology. In the pilot study, which was TCC pilot, we looked at a group of acute coronary syndrome and heart failure patients. And the heart failure patients are older. And in fact, they were more compliant and they used the devices much more than the younger population, i.e. me, don't go and get care from a GP. So I do think it's how you, how I found we've encouraged 122 to come on board is, I suppose we still deliver our model of care that's hands-on. I sort of say this is just going to support what we're doing from a human point of view. It just allows me to be much more interactive. We're only a small team. Most heart failure teams are small teams, but we've got big numbers of people to support, and this is a surrogate support system, but still allows you to provide that human interaction.
Great. Thank you, Jim.
Thank you.
Well done. I'm now going to welcome my esteemed colleague, Lauren Sturgis, Director of Nursing and Midwifery from St George Hospital, to join us to present her paper on Collaborative Leadership Program Enabling Future Nurse and Midwifery Leaders, which will focus on the development of leadership skills across the workforce and the importance of collaborative leadership in nursing and midwifery. Welcome, Lauren.
Thank you, Karen. That's a bit of a tough act to follow, actually. So as Karen said, I have the privilege of presenting the Collaborative Leadership Program Enabling Future Nurse and Midwifery Leaders. I would like to start by acknowledging Liz did steal a bit of my thunder earlier, so I do apologise if this is a bit repetitive, but what it really talks to is the recognition and the importance around establishing really robust leadership programs for the next generation of leaders. And I certainly feel an onus of responsibility around that. That needs to be our legacy, and how we get the next generation prepared for what they need to help navigate. So what we're largely going to talk about today is how our Future Mums program has developed over the last 13 years. As you saw with Prince of Wales, they have had it established for some time. We're very proud that we initiated the Future Mums program, as I mentioned, 13 years ago. And as we talk through it today, you'll see how it's evolved to now include our future CNE and CME program. I do apologise to the midwives in the room, but obviously when we're talking about our future NUMs, we're also talking about our future mums and our future CNEs and future CMEs. And I would also like to start by acknowledging Jodie Bancroft as the nurse manager of the lead team, who has been instrumental in developing the future CNE CME program with her wonderful team of educators as well. So I would like to pay my respects to the traditional custodians on the lands we stand and the lands that all of our members online are joining from today as well. In acknowledging the alignment to the strategy, there's a number of red circles and red arrows there, and I really feel as though, although I'm fairly biased about this program, It really does have the capacity to underpin so much of what we do and how we deliver care across all of our services and how we support and succession plan our workforce. So they are the areas that I felt both programs align with. Now just very quickly, in terms of background, you know, I've always felt as though not many other industries would expect a, you know, somewhat capable nurse off the floor to all of a sudden manage a multi-million-dollar budget, a service that runs 24/7, and, you know, upwards of 10, 20, 30, 40 staff. But that's exactly how mums and mums were picked many years ago when I was a mum. You know, somebody identified that you probably had half-decent communication skills, and so therefore if you could just run this really complex service, that'd be terrific. And really we were all thrown in the deep end, and I'm really showing my age there, but we were. And so a big part around this project was recognising that we needed to do that better for our workforce, absolutely. And appreciating that that role has only become more and more complex over the years as it has developed. So part of the other issue is at that time a lot of us had excessive leave because you couldn't take leave because there was no one to backfill you. So instrumentally a big part of addressing that, and through adequate succession planning, we now have a program that allows people to take a break as they so rightly deserve, and also avoids excessive leave, which is an added bonus. But what we really want to be making sure is that we are planning and facilitating adequate leave relief. A service can't run based on one person, myself included. So at the end of the day, you need to have succession planning processes in place where the service and the staff can continue on as if you are there. So that was a big part of the background. And particularly around some of the drivers is ensuring the capability of the registered nurses and midwives in the role. As I touched on, the system is becoming more and more complicated, and what we're starting to see is this skill set complexity gap. The patients and the services becoming more and more complicated, and as we see the retirement of our baby boomer generation, we're starting to see the skill set of the workforce somewhat diluted. So in the challenges around addressing that skill set complexity gap, we need to really be building the capability of the workforce across all levels. As I mentioned, it's our responsibility to make sure that we're adequately succession planning into these roles that are so critical in the organisation, and that we're fostering a culture around professional development and succession planning. Now, what we really wanted to focus on today is about the evolution of our Future NUMS program into now our Future CNE program, and starting to recognise, well, over the course of how it's been run over the last couple of years, is the strength and the power in having a collaborative leadership team between the NUM and CNE, MUM and CME, collectively and supporting each other and collaboratively working together to guide the direction of that service and the patients and the workforce. You know, we've moved away from a focus where the leadership just comes down to the NUM. That is no longer the case. It's about recognising the role our CNCs and CMCs play in leadership, and now the collaboration between the CNEs and the nursing unit managers and mums. So it was really an opportunity for us to redefine the collaboration of that clinical leadership team and the support and the opportunities that then subsequently provided. So probably like many of the areas that you'd be familiar with, most of, all of our wards have a NUM, MUM, CNE, CME, plus or minus the CMC/CNC. So what we wanted to make sure is that every role has really clear role clarity, and part of that was the co-creation of the ways of working within the clinical leadership team, and making sure that those roles and responsibility are clear not only to the individuals but to the workforce that they're supporting and managing. So the clinical leadership teams then therefore collaborate on all staff performance reviews, the probation meetings, performance practice concerns, patient safety issues. It extends across the entirety of the service. The CNE and CME now work together with the NUMS and MUMS as a collaborative and united team. And what we found too is it makes it a lot clearer for the workforce around who's doing what and what sits where, and ultimately they feel more supported in that sense as well. So very quickly, just a recap on the two streams or the programs that we have. They do run closely together. but equally have their own sort of unique structure as it's set out. The future mums and mums both do an orientation day. They have the second 30 days, the collaborative leadership day, which I'll talk through a little bit more. The work shadowing week for the mums, similar to the Prince of Wales model, they spend a day with each of the key stakeholders or some of the key stakeholders across the organisation. Oh, 5 minutes. That's really important in terms of making sure that they actually have an understanding of what our roles do. I mean, a lot of people, that is hard for people to know what we do all day. And so we find that really positive feedback from the RNs when they spend time with us is they get a bit of insight into the kind of roles and responsibilities that we're undertaking as well. And the second week is a work shadow week where they spend with their preceptor nuns. Very quickly, you can see the C&E program there. And what is fundamental is the box down the bottom and how we set up the structure around the program. So they all have a preceptor. They have structured clinical reflective supervision sessions. We have a very robust mentoring program that they're all allocated. The leave relief opportunities that occur across the entire organisation is centrally managed, so anyone who's taking leave is replaced with a future NUM or C&E. And this NUM C&E masterclasses help to ensure ongoing learning and development. That's a very quick snapshot of the orientation day and the supportive leadership program for the NUMs. Reflective supervision, as I touched on, this has been a really important development and evolution of the program, is that they now have structured and robust reflective supervision sessions independently. The C&Es do theirs and the NUMs do theirs, they're not together. But they both have the opportunity to have clear, structured, reflective supervision with independent facilitators, and we have a really clear, robust escalation process around any concerns that might come out of this. But the feedback again is that they feel like it's a really safe space, that they can debrief, they can get advice and provide support to each other, which again creates a collaboration with them as individuals and as a group. I'm now going to try and talk a lot faster. The collaborative leadership workshop, this has been a really, really positive development, and this is another credit to Jodie and the nursing exec support manager that run this session. They spend the day together, so the future NUMs, mums, future C&E, CME spend the day together, and they really have the opportunity to work out the different role delineations. They have this really strong, robust conversations around leadership and what that means for them. There's a panel discussion, previous future NUMs, mums, CNEs, CMEs, you get the drill. They get the opportunity to ask people with previous and recent experience about their experiences. And it's a really positive day that they actually get to, because they're from across an entirely large organisation. Some of these people have never met each other. So it's another really great way to build the relationships in another safe space that can help clarify that leadership role as clinical leaders on the ward and those ways of working, and so this has been a really positive development out of the program. Leadership and mentoring, probably similar to other mentor programs that some of the facilities might have, but initially we did an EOI to get expressions of interest from people that wanted to undertake the mentor role. That was really integral because you can't force mentoring on someone. You can try, but it won't probably be successful. We wanted these people to really put their hands up and recognise the role that they can play as mentors, and they got to participate in a mentoring masterclass, which was really, really well attended and got really positive feedback, because lots of managers and educators have experience but may not know necessarily the nuances of how to be a good mentor. So by identifying those that wanted to participate in the mentoring program, we were then better able to align them to the future NUMs, mums, CMEs and CMEs. So it definitely needs to be mentee-led. They have established sessions for 1 hour for the 12 months, both programs go for 12 months. And there is a mentoring agreement contract that both engage in. So it's really clear from the outset what this relationship is going to look like, and it helps to add to the robustness of the program overall. So very quickly, and we have done some previous publications on the program, we're looking at how we're now going to move into the next iteration of publications to recognise the collaboration between the C&E or the educator role and the management role. But over the course of the last 13 years, we have had 95 participants in the management program, and around 81% of those have secured equivalent mum positions or more senior leadership roles. And the CNE program hasn't been running as long, but it's been running for the last 3 years with a successful rate of 72% of those educators securing CNE positions or equivalent and higher leadership positions. So it's a program that we're exceptionally proud of. It has a lot of capability. It allows the workforce to recognise that we invest in them. It builds the skill set across the organisation. It really helps to build relationships. And I think it helps us run this place every day because we've built the skill set of some of the most integral positions across the organisation. So this was the class of last year, and they are really doing excellent, and we look forward to continuing it in the future.
One question.
Thank you for that. Hi, thanks for that presentation. That was really inspiring. I noticed you had emerging CNCs, and do you see, and this is to all the other organisations suggested, do you see a program and all the CNCs in the room? Would there be room for a CNC succession plan sharing strategies? Because I'm speaking just from CNC and maybe on the others in this room about succession planning and about when those roles come up. Especially that 5-day
the
shadowing and being covered when we're off and so forth. I think space for the CNC. But do you see that?
Look, it's an excellent question and something that I have had open discussions with my CNCs and CMCs at our meetings because I do recognise it is a bit of a gap, and I don't ever want it to be perceived that there's all this investment in educators and managers which might undermine the perception around the CNC and CMC role, which is absolutely not the intention. So I think it is a gap that we have, and I think it is definitely something that we need to be looking at. Because they do have such an integral role. It is a bit more complex because essentially we are trying to teach the technical skills to mums that can then be fluid across the organisation. All of the CNC and CMC roles are so unique, it would be hard to have sort of an organisational program that pluck these RNs off the floor and filter them out across the facility. But that's not to say that we shouldn't still be making sure that we've got adequate succession planning and in place. And I speak for most of the CNCs when I assume that a lot of them have individuals that they support and mentor and have identified as having the skills and capability. We need to make sure that we're supporting the CNCs and CMCs through that, what that looks like. And that is definitely something that I am keen to progress with the group, absolutely. I'm not sure if any of the St George CNCs or CMCs have anything to add.
Mary?
The mentoring project that you've introduced is wonderful. It's wonderful for the person who's being mentored, but it's also wonderful for the mentee.
Yes.
Because we learn from each other.
Yeah.
And the initiative that you've done with the CNCs with the mentor program is wonderful. And giving us education to be better mentors is wonderful.
Yeah, that's great. I mean, I definitely think how the CNCs evolved can be similar to the way the NUMs evolved in the past, where you got plucked off the floor and then now you're expected to coach and mentor and not always having been given the support, advice or direction on how to do that. So I think that mentoring program is really essential not only for the mentee but also for the mentor as well, to give them the support so that they feel confident in what they're doing. Taking up too much time now, I talk too much.
No, I was just going to add that for us as well, we would be keen if there was some work that we could do together and even explore what the CNC pathway could look like around some skills across the 5 domains, but then obviously that specialty based is learned within the specialty, but there would be some shared opportunities there, and it is absolutely the next step. So, but this is a great presentation and of the work that you've been doing. I'd just like to acknowledge that Lauren and the St George Executive have paved the way for us across many of our organisations. I know the Royal also have an emerging mum program, City Eye and Prince of Wales as well have followed you. So thank you for your leadership in the space.
Our pleasure.
Our final presentation
question of the afternoon. It's been a wonderful session. So I would like to invite Anna Scott Murphy, the Nurse Unit Manager from the Newborn Care Centre at the Royal Hospital for Women, and Ruth Jackson, the Nurse Educator from the Newborn Care Centre, who are here to talk to us about optimising neonatal nutrition. Welcome.
Thank you. Good afternoon. We've been hearing all about our lovely big people all day, and it'll be only right to finish with a little look at our littlest people. So Ruth and I are here to present our project, which is optimising neonatal nutrition and introducing a nutrition bundle in the neonatal intensive care unit. And our alignment with strategy is delivering high-quality, safe, person-centred care, and specifically the strategic actions, ensuring that the patient is at the centre of what we do, and creating the conditions to utilise evidence to assist in developing patient-centred care. Okay, so we're here from the Royal Hospital for Women's Newborn Care Centre, and a little bit about us just to set the scene. So the Royal Hospital for Women's Newborn Care Centre is one of the largest perinatal surgical NICUs in New South Wales. We have 46 beds and a dedicated team of over 200 medical, nursing, allied health professionals. We're a very busy NICU with over 1,000 admissions each year, and we offer highly specialised care for extremely preterm and sick newborns requiring medical and surgical interventions, and offer a multidisciplinary approach, collaborating with skilled fetal medicine specialists at the Royal Hospital for Women and paediatric subspecialists from Sydney Children's Hospital. So a bit about nutrition for preterm infants. Nutrition is crucial for preterm babies to support their growth and brain development, immune function and overall health, improving developmental outcomes and reducing the risk of long-term complications. Extremely low birth weight infants are at risk of malnutrition and necrotizing enterocolitis because of their immature digestive and immune systems. Their intestines are underdeveloped, making it harder to absorb nutrients and fight infections. Extremely low birth weight infants have limited fat reserves, delays in initiating feeding, and ongoing feed intolerance. Additionally, there's prolonged reliance on IV nutrition like TPN, and rather than feeding through the gut, this can diminish mucosal integrity and impair functional integrity. So we've had a long journey with nutrition in newborn care. Starting in 2015, we were highly involved in the standardised consensus of neonatal nutrition for TPN. We introduced probiotics in 2017 and pasteurised donor human milk in 2018. Our first nutrition bundle was in 2019, and that focused on growth targets, introduced fennic protein and milk warmers into the NICU, and we began to weigh our powdered cow's milk-based fortifiers. And whereas we previously had a sort of a bit of a half packet, full packet sachet dropped into a pot of milk. So we got a little bit more technical. 2022, we recruited our first NICU dietitian. And 2023 was the development of our nutrition MDT, and we revised our nutrition bundle, and this is what our project is about. So our nutrition bundle was developed by an MDT that included doctors, nurses, dietitians, and lactation consultants. And the bundle focused on many different aspects of neonatal nutrition. Our project specifically, though, focused on implementing an exclusive human milk diet. We recruited allied health assistants, so AHAs are clinicians who work with various allied health professionals. In NCC, we used AHAs to assist with feeding preparation and growth monitoring. We also looked at nutritional goals for preterm infants, and this included reducing malnutrition, achieving physical growth targets, with a weight gain of 21 grams per kilo per day and length and head circumferences of 1.1 centimetres per week. Our goal was to minimise the risk of neck and improve neurodevelopmental outcomes. So I'm going to talk about an exclusive human milk diet. So what is this? So this is a diet for our premature babies that consists of mother's own milk, whether that's with pasteurised donor human milk and human milk fortification. So we were the first unit in Australia that introduced a exclusive human milk diet to our patients, and this was using a product called Humavant, and that's supplied by Prolacta Bioscience. So what is Humavant exactly? It's made exclusively from 100% donor breast milk, so the fat from the top of the donor breast milk is skimmed off, and that is what the product is. It's concentrated, pasteurized liquid, and we are able to have this in different calorie doses. We add this product to mum's own milk or PEHM to increase the nutritional content to help meet the high nutritional needs of our population. It is a very expensive product, and it is imported from USA, so there were lots of processes involved in getting this into Australia. We offer Humavant to all of our babies that are born less than 1,000 grams at birth, and we know that an exclusive human milk diet is associated with healthier growth velocity, reductions in rates of neck, bronchopulmonary dysplasia, and late onset sepsis. However, reports from NICUs globally indicated there was an increased workload for nursing staff, and it is a consideration in their staff-patient ratio allocation. So we also looked at nursing workload feeding challenges and introducing the allied health assistants into our NICU. So prior to the implementation of this nutrition bundle, we surveyed nursing staff regarding nutrition. This identified that there was an increased workload that consisting of the individual weighing of fortification doses. The scales that we used were very small volume, but they weren't accurate enough for the doses we were giving. It was also time consuming for our nurses to individually weigh these doses. There were concerns from nursing staff on the tolerance and potential side effects of the fortification, and this could be abdominal distension, vomiting, generalised discomfort for our patients. The survey showed that nurses missed fortification doses 79% of the time of their shift, so quite a high amount of doses missed, which is bad for our growth. There was lack of understanding from the nursing staff on the benefits and importance of fortification. We didn't have any routine education on our neonatal nutrition. And also showed that 50% of nurses missed growth measurements 75% of the time. So we weren't able to accurately measure our babies. So to address these challenges, we implemented the AHAs into our NICU. So they took over responsibility for fortification preparation of both the cow's milk-based fortification and the Humavant. They implemented high-performance specialised small-dose weighing scales to measure the fortification. They are responsible for defrosting and preparing Humavant feeds with mum's own milk or PEHM, and they also audit our growth measurements weekly. The post-AHA implementation survey found that nurses reported significant improvements, including fewer missed fortifications, reduced feed preparation time during day shifts, fewer missed growth measurements. However, there was some increased feed prep time on night shifts. So the introduction of the AHA role enabled nurses to focus on more complex patient care needs, improving the quality of care delivered. Ooh, I don't know what I've done. Okay, and our final part of our project was our nutritional goals. So this part of the project evaluated malnutrition for infants less than 1,000 grams at birth that received Humavant fortification. And we used our weight for age Z scores to evaluate this malnutrition, and this was done at 34 weeks corrected gestation. So there was a pre and post implementation study that evaluated deviations from the weight to Z score as a marker of malnutrition, and this included how severe the malnutrition was for our babies. The study showed that 88% of infants in the control group had mild to moderate severe malnutrition compared to 39% of babies that received Humavant. The study also highlighted that there was a reduction in the severity of malnutrition of these babies. The study groups, so babies that had Humavant, had no cases of NEC compared to an 11% incidence in the control group. So this showed us that the exclusive human milk diet directly improved patient outcomes. So where are we going from here? The nutrition MDT are looking at where we can refine and improve the nutrition bundle to ensure we are delivering safe, high quality, patient-centered care. So areas that we've identified through this process are addressing the night shift workload. So looking at ways we can improve the time it takes to make up feeds for our night nurses and the timing of defrosting of milk products, so it's not expiring on their shifts. We are looking at increasing our AHA coverage from 5 to 7 days a week, so we can have them all the time, and also hiring an AHA that only works in newborn care. Currently they're shared with Sydney kids, so we often have leave relief problems. Looking at doing an ongoing cost analysis, so reviewing the cost benefit of the nutrition bundle and will this be sustainable in the long run, and hopefully with our lovely exec support we can continue this. And looking at neurodevelopmental outcomes for babies that received Humavant, so looking at timing to assess these babies in our growth and development clinic and whether this has improved their neurodevelopmental outcomes. And also micronutrient monitoring. This was an interesting part of our project that came up. So babies that received an exclusive human milk diet highlighted that they may lack certain micronutrients, such as zinc, and they required closer monitoring of their blood levels and whether they needed treatment for these micronutrient deficiencies. And that is it.
You might be off the hook. Any burning questions, just given the time? Another great presentation. Thank you both for sharing your work with us. So to close the session, I think you'd have to agree with me that the presentations this afternoon have shown the depth and breadth of the work that our nurses and midwives are leading across SESLHD that really impact on patient, family and staff outcomes. But I think most importantly also contribute and shape the cultures in which we provide care. And most importantly, what I've heard throughout the whole day is our commitment and passion around providing safe, person-centred care. So well done to everyone. It's been a pleasure to chair the afternoon, and I'm going to hand back over to Dan.
Thank you so much, Karen, and for being our chair for the final session. Please join me in thanking Karen for her efforts this afternoon. Okay, this is the exciting part of the afternoon. Now we're going to move into our session 4 presentation voting. So we'll have a QR code on the screen. Robin's already ready. Oh, right. I was like, gee, you're all set to go, Robin. I'll bring up a QR code on the screen, and Mel's going to time us for 5 minutes, and she'll let us know when the 5 minutes is up. We'll tally the voting, and whilst that's happening, Kate will come up to the stage and run through some end-of-day remarks, and then we'll seek your support in completing our evaluation. If you haven't already, there is a QR code in the program to complete. And for those who haven't had time to complete their safety attitudes questionnaire, you have the wonderful Maggie and Annie at the back of the room who have a QR code for you, so you can complete it whilst you're waiting. All right. So I'm going to click over and we'll have 5 minutes. Ready, Mel? All right, let's go. Please tell me it's working. Yeah, working. 2.
That's it.
That's That's just for this session.
Just for this session, thank you.
The other sessions have been judged by
Oh, judge independent.
On those presentations, and as Sam said, we could also the feedback QR codes in the program, and Maggie and Annie are coming down as well if you want to get that done. So many QR codes. Less than a minute to finish your vote. Okay. We close voting now on the presentations from the final session. I'll probably just note that the first three sessions we had independently judged, obviously by people that aren't part of the facility or have vested interest in the presentations being presented. Brendan did the first session for us before he left. So thank you for everyone for that, but we really wanted the audience's participation in some of the judging, so thank you. Look, I'm just going to start with some final comments. I can see Dan up the back tallying up those votes. So I just want to start by just saying what an incredible day today has been. I probably started to think about this probably about 2 years ago, maybe about a year into my role here. And it's really taken that amount of time and I suppose a bit of courage and confidence from my team to pull today together. It's been a huge undertaking. It definitely, whilst it is the inaugural one, it will definitely not be one and only. We do plan to do this annually moving forward, and I think all of us here today have been witness to the incredible work that's going on within the profession, and I don't think any of us are surprised. You know, we see it daily, but you know, to invest the time and spend the full day in this space is so rich and rewarding. So it is something that we will repeat, and I do hope that the people attending today will also go back to their peers and colleagues and think about what potentially could be put forward in future times to present. Excellent. I'll ask you just again, there is the feedback QR code in today's program. If you could just fill that out you know, before you leave today, that would be incredibly beneficial. As I said, because it's our first one, we would really love some feedback and to understand, you know, what's worked well and where we can improve as well. I have some thank yous I would like to make before we present the awards. But can I just ask you at the end, because I always know it's a bit of a mad rush to leave here. We do have some rubbish bins just outside the doors. Can I just ask you to take rubbish with you? The team's been here since incredibly early this morning. There's a recycle bin out there as well for your plastic bottles because we have used a lot of plastic today. So if I could just ask that of everyone along with filling out their feedback. From today, we will share with obviously the permission of the authors if they are permitting it, to share the posters and presentations and also the recordings from today. The team will be in touch with each of the presenters regarding that.